أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي رب زدني علما آمين يا رب العالمين. Assalamu alaikum and good afternoon everyone, faculty members, respected guests and doctors in training. My name is Umar Nisar Sheikh. I am a consultant in pathology department at Shaukat Khanum Hospital. I am pleased to welcome you all to the 22nd Annual Shaukat Khanum Cancer Symposium in November. I would like to extend a deep, warm welcome to all the distinguished speakers who have traveled long way and to those who have taken their precious time to record the videos for the symposium. So today's workshop has been designed to include approximately 1 hour each long lectures, followed by the question and answer session at the end with the speakers. Please write down your questions and send us via Zoom link. We will ask the speakers your questions at that time. I truly hope that you will have a really good session today and it will be very rewarding. So our first speaker and actually my first mentor in the field of pathology will be Dr. Elizabeth Montgomery. She is well recognized all over the world for her contribution in education, and she has published more than 300 papers as well as 80 or more book chapters and books, mostly on gastrointestinal pathology and soft tissue pathology. So she will be giving us 2 lectures today. She is currently a professor of pathology and serving as a vice chair in anatomical pathology section of University of Miami, Florida. Uh, I started my pathology career with her, and she is so humble and ethical while she keeps a very happy and smiley face. So she has helped, like me, many other residents in training to achieve their goals, and I will be in debt to her all my life. So without further ado, we will start the first lecture of Dr. Elizabeth Montgomery. The topic for the first lecture is gastrointestinal dysplasia, top to bottom. So here we go.
Hello, everyone. My name is Elizabeth Montgomery. I'm a pathologist at the University of Miami in Miami, Florida. And let's get started. I'm going to share my screen. Here it goes. And now let me get the slides pulled up. All right, so we're going to start with some dysplasia topics in the gastrointestinal tract from, well, the esophagus to the anus. Here we go. We're going to discuss some squamous dysplasia of the esophagus. We'll consider some esophageal columnar lesions as well as gastric ones. And then we'll just say a bit about the small bowel. We'll talk a little bit about colitis-associated dysplasia and save the anus for last, but we're not going to talk about last very much. In the esophagus, what are some precursors to squamous cell carcinoma, or at least putative precursors? One is basal cell hyperplasia. This fails to retain Lugol's iodine, and then a biopsy is taken, and we're looking for greater than 15% basal cell thickness. It hasn't gained much popularity in the US where I practice, but it's certainly popular in other areas of the world. The next one that I find really fascinating is so-called epidermoid metaplasia, which has gone under these other names and is probably a precursor. And then, of course, there's conventional low and high-grade squamous dysplasia. All right, so this is the so-called epidermoid metaplasia. You can see this is an endoscopic image, and there's the lesion right there. Of course, the term leukoplakia means a white patch, and they were originally described in the buccal mucosa, but nowadays, of course, we've noticed that they're in the esophageal squamous mucosa as well. Here's a particularly dramatic example with really a whole lot of this weird process. All right, so as we just saw, the colleague doing endoscopy will see plaques of white, thick mucosa, but sometimes they're reddish. and they tend to be more prominent at the distal part of the esophagus. And then the biopsies are really pretty boring. They just show a little bit of hyperplasia and hyperkeratosis and a granular layer, just like skin. So, if you look at patients who have this phenomenon, and I've quoted a couple of early studies, the patients with it tend to like to drink alcohol, they like to smoke cigarettes, they have a higher incidence of head and neck squamous lesions and conventional dysplasia and cancer in the esophagus when compared to those people who have Barrett's esophagus. Of course, in these early data, the colleagues at Mayo Clinic did a better job than we did because they had more cases, but our conclusions were the same. This is a nice example of epidermoid metaplasia, and what you can see is this granular layer, which should be absent in the esophagus, and then this nice parakeratosis. I'm sorry, hyperkeratosis. My goodness, I've made an error on the slide. All right, and this is more of it, again with this hyperkeratosis, not parakeratosis, and a granular layer. Here's one that was actually associated with invasive squamous cell carcinoma. And you can see that very, very nicely here. You can see that there's a little bit of the granular layer, the fake granular layer left, even after the lesion has already progressed to invasive squamous cell carcinoma. Here's another such example in which we see epidermoid metaplasia associated with high-grade squamous dysplasia or intraepithelial neoplasia. And here's that area at higher magnification, and we can see the granular layer pretty well in this image. So the cool thing is that my colleague Ator Singhi was able to micro dissect lesions from the same patients who had the whole sequence of epidermoid metaplasia, of course, normal as well, dysplasia, and carcinoma. And he found the same P53 mutations in a subset of the epidermoid metaplasias that then were found in the dysplasias and invasive carcinomas. So the same mutation in a given patient with the full spectrum of lesions. Pretty cool. Of course, there's also something analogous that can be detected in the mouth called oral proliferative verrucous hyperplasia. This is unassociated with human papillomavirus. The key mutation is with TP53. And you can see something very similar here. And notice this abrupt demarcation between the non-granular layer area and the area with the hyperkeratosis in the granular layer. This is an image taken from the cited paper by Lester Thompson. All right, so this is another phenomenon. Just something to know about squamous cell carcinoma. You can see in the biopsy on the left, these are two biopsies from the same patient on the same slide. You could see an obvious high-grade squamous dysplasia, and it looks like we have an invasive carcinoma here. And then there's a different type of fragment on the right. So let's take a look. Here's part of that squamous lesion on the left, very obviously at least high-grade dysplasia. And some would argue that this focus is good enough evidence for carcinoma. There was certainly obvious carcinoma in other fragments. And then I draw your attention to this piece. So you can see that the top half of the biopsy looks fine and the bottom half looks neoplastic or dysplastic, but it only occupies less than half of the thickness. And here it is at higher magnification. In all likelihood, this is just intraepithelial spread or lateral spread of a squamous carcinoma or high-grade dysplasia invading intraepithelially. So if you see this alone on a biopsy, please have your endoscopy colleague go back and take lots more biopsies. Let's think a little bit about the columnar esophagus and stomach. So one thing that comes up a lot is how do we define Barrett's esophagus? And it depends on where you live. So British colleagues and Japanese colleagues in 2014 wanted to see any columnar epithelium with or without goblet cells that was at least a centimeter above the gastric folds. The idea to get rid of the hiatal hernias and just the cardiac type mucosa. They retained those criteria in 2018 when they updated their guidelines. The AGA has been a little more circumspect on how long the segment would be, but the American College of Gastroenterologists in 2016 kept the requirement for goblet cells, but added the length requirement just to be very rigorous. And they continued with this viewpoint when they updated their guidelines in 2022. The reasoning in the US for retaining the requirement for goblet cells is from several angles. There were a couple of studies from the University of Southern California in which the colleagues only found dysplasia or carcinoma in patients who had intestinal metaplasia, and their early carcinomas were accompanied by intestinal metaplasia. But of course, the patients in these studies were all on very high quality systematic protocols. When we looked at such cases back when I was at Johns Hopkins some time ago, my colleague Kayvon Salimian learned that if we took our early cancers, more than 90% of the patients with early cancers, which were treatment naive for chemotherapy and such, had a background of intestinal metaplasia. Of course, that tells you also that a small subset did not have intestinal metaplasia in the background. Here's my favorite trick for avoiding overdiagnosis of dysplasia. And that's what I like to call the 4 lines. It's a great clue to determine whether neoplastic or whether columnar epithelium in the esophagus is dysplastic or reactive. You see this in gastric cardiac mucosa, and you also see it in Barrett mucosa. So let's have a look. So this is a biopsy from the tubular esophagus. There's a goblet cell. So in the US, that would be Barrett's esophagus. Line 1 is the apical mucin cap. Line 2, the base of the cap. Line 3, the row of cytoplasm. Line 4, the row of nuclei. This is a bit tangential, so this looks stratified, but you can see where everything is perfectly embedded, that you can really see those stripes or lines or layers or whatever you want to call it. And they mean that the cells are lined up right next to each other, like they're standing like I don't know, the guard out of Buckingham Palace or something like that. Here's the same phenomenon that we can see in the stomach. This is cardiac mucosa, and I've indicated those lines, again, indicating well-maintained cell-to-cell polarity. Same phenomenon again, but I had to take an oil immersion picture. And here's that phenomenon in a nice example of Barrett's esophagus. It's not so easy to see where it's tangentially embedded, but you can see it quite nicely in the areas of the section that are nicely embedded. This kind of helps us segue into defining indefinite for dysplasia. Wait, I'm defining something that's not defined? Never mind. So, of course, indefinite was originally defined in inflammatory bowel disease by answering 2 questions. And this is kind of harkening back to Robert Riddell, who was the first to think about this in 1983. Number 1 is the epithelium unequivocally benign or reactive. And number 2 is the epithelium unequivocally neoplastic or adenoma-like. And a no to both questions should be indefinite. Well, we were smart Alex back in 2001 and tried to define indefinite. Oops. And we deliberately defined any epithelium that looked a bit dysplastic at the bases of the pits but had surface maturation as indefinite, which suggests that you can't have dysplasia with maturation. Of course, everybody knows that biology isn't quite so black and white, and there will be in between cases. So you can define indefinite as showing more surface maturation, a little architectural crowding, and then all these other sort of vague, very muddy things. But I think we all know that inflammation is frequently a factor. And then for me, in order to know that something is dysplastic, I like to see a sharp transition between an area that looks like it's fine and not dysplastic and the area in question. So here's my dirty laundry. Here's my mess up from the past. This is the sort of thing that I used to diagnose as indefinite for dysplasia. I was wrong. Here you can see there are these neutrophils here. There's a gradual transition to obviously non-dysplastic mucosa on either side. And of course, tangential embedding is a factor. And as you look, you'll see that those lines are there. Here's another example of my old errors. I've drawn an arrow showing a gradual demarcation between an area in question at the right and a clearly non-dysplastic zone at the left. If you look to the right, you'll see that more dramatic area still maintains those lines. On the other hand, we've got our lines here and up, but they're gone here, sort of here, but they're definitely obscured. And for me, this is low-grade dysplasia. So this is an interesting study we did. We refined our criteria at separating low-grade dysplasia and non-dysplastic Barrett's, as I just showed you. And we found that if we did things our new way, we did not harm anybody. And we had the 10-year follow-up. So this is very embarrassing, but as of 2007, we were vastly overcalling indefinite for dysplasia, around 10%. And by 2016, we'd really pretty much extinguished that behavior. Nowadays, I scarcely ever use the term unless I'm absolutely forced. So this is an example of a lesion that one could maybe call indefinite for dysplasia. This area looks a bit atypical. The surface looks a bit atypical, slightly hyperchromatic, but the cells aren't terribly big. And as you go to high power, I'm sure many of you are saying, this is probably maturing and the deep stuff is probably fine, but we call this indefinite. So ideally in your practice of Barrett's, you should have less than 5% of any of those categories listed, low grade, indefinite, or high grade. But you should actually be lower than all that. And you really should have very, very few indefinites if you're sharing your cases and thinking hard about them. Unfortunately, there's some variant forms of dysplasia that some of us struggle with, and the initial studies were all using intestinal type or adenoma-like dysplasia, but there are some variant patterns. This is a classic intestinally differentiated low-grade dysplasia. It almost looks like a tubular adenoma of the colon, except that we have this lovely gastric gland underneath. This is a high-grade dysplasia. We have loss of nuclear polarity. And this one even has some Kolchitsky cell differentiation. I have this theory that this is the precursor to neuroendocrine carcinoma, but I haven't been able to really convincingly prove it. On the other hand, here's some dysplasia with foveolar differentiation. Lines are gone. Nuclei are larger and more hyperchromatic than usual. These can be very subtle. And here's high-grade foveolar differentiated dysplasia in the esophagus. This is quite clearly dysplastic, but it has all this foveolar type differentiation. This happens to be a periodic acid Schiff-Alshin blue stain, and the color of the mucin here doesn't quite look like foveolar mucin, but these are not goblet cells. On the other hand, the adjoining mucosa did have a few goblet cells. This is a really cool case of, if you will, cardiac differentiated or pyloric type differentiated dysplasia in the esophagus. And here's another example. Notice that there's a monolayer of nuclei in the low-grade dysplasia and loss of nuclear polarity in the high-grade dysplasia. Let's work our way to stomach. Can we use the lines for gastric biopsies? Not as well as in the esophagus, but yes, we can. All right, so let's take a look. This can be very helpful in patients with severe erosions or reactive gastropathy in the antrum. You can see that there's an erosion here. As we get over here, our lines are very easy to see, and then suddenly here they're not so easy to see. And here's high magnification of this very nasty reactive looking stuff right by an erosion. But if you do a PAS stain, you'll notice that there are the vestiges of the apical mucin cap. That's a clue that in fact this is not dysplastic but reactive. Here's a really dramatic example of reactive gastropathy with striking reactive epithelial changes. And it's very nice and reassuring to see that delicate apical cap of mucin on a PAS stain. Let's think a little bit about gastric adenomas and gastric dysplasia. So if we look in a Western population, and I'm in a Western place, we can talk about gastric adenomas that are intestinal type, but biologically they're just polypoid gastric dysplasia. There is a foveolar type adenoma in the stomach, and there's a pyloric gland adenoma. Uh, these have GNAS mutations, whether they're gastritis associated or syndromic. And then there's the rare so-called oxyntic gland or chief cell adenoma. These also have GNAS mutations. But our European colleagues are sort of annoyed that we don't just call gastritis associated polypoid dysplasia lesion rather than adenoma, very much the way we regard the dysplasia associated with inflammatory bowel disease. Either you can see it and remove it, or it's flat dysplasia that you can't see. That's the scenic guidelines in the colon. So this is a bit confusing. So if a polyp with pyloric gland differentiation is found in a patient with autoimmune gastritis and pyloric metaplasia, that's not an adenoma, but oh, the same polyp in a patient with familial adenomatous polyposis without gastritis is an adenoma. And yes, intellectually that's true. And you can say the same thing regarding intestinally differentiated polyps that are found in the stomach. So this is a beautiful example of a biopsied polyp from the stomach. It looks very much like a colorectal type adenoma. So of course the term intestinal type adenoma has been used, even though it's polypoid dysplasia. And here is the PAS Alcian blue from that case. And you can see for sure that this is from the stomach. And those of you who are more awake than I am can make out a few goblet cells down there. This is the patient's flat mucosa. Obviously, it's abnormal and it has plenty of intestinal metaplasia, both of the complete type on the left and the incomplete type on the right. And here's the periodic acid Schiff Alcian blue stain from that one. On the other hand, this type of adenoma is the true adenoma of the stomach. It has arisen in uninflamed oxyntic or parietal and chief cell bearing mucosa. It is a tiny little thing in the whole stomach, sort of like usually a colon adenoma is a tiny little thing in the whole colon. And it has low-grade dysplasia with foveolar differentiation. And here you can see that at higher power. Some of you might say, oh, well, why isn't this just a fundic gland polyp with surface dysplasia? And it may well be, I can't tell you. The point is that this is foveolar type dysplasia, and unless you have the special form of familial adenomatous polyposis called GAPS, gastric adenocarcinoma proximal polyposis, these things basically never progress to cancer. Here's higher magnification of such a lesion. And here's a PAS Alcian blue stain showing you those apical mucin caps. Of course, my favorite is the pyloric gland adenoma. If you take out the fundic gland polyps, it accounts for almost 3% of stomach polyps based on a classic paper from Michael Feet. And it tends to affect mostly women. And there's often an association with autoimmune gastritis because of pyloric metaplasia, then this pyloric dysplasia, and these do occasionally progress to cancer. Here's an example of one in the stomach, monolayer of nuclei, ground glass cytoplasm, and yet another one, monolayer of nuclei, ground glass cytoplasm. This is not a foveolar adenoma. This is not a hyperplastic polyp. This is a PAS Alcian blue from one of these, and instead of getting a crisply defined apical mucin cap, you get this sort of smudgy stuff. For those who like doing immunohistochemical stains, pyloric gland adenomas express MUC6, and many of them co-express MUC5. You don't need to do these stains, but it's kind of fun to see them in pictures. Beauty contest. The pyloric gland adenoma is seen below the surface, ground glass cytoplasm. The foveolar adenoma is on the surface and has perfect foveolar epithelium, just enlarged nuclei. The weirdo one is the oxyntic gland adenoma or chief cell adenoma. Colleagues in Japan also named these gastric adenocarcinoma of fundic type, even though all the cases had benign follow-up. they have GNAS mutations. There seems to be one case report of a metastasis, but they don't show a picture of it, or not a case report, but it's in a series. I'm not sure why they don't show a picture of it. And anyway, be that as it may, there's a move to just call these oxyntic gland neoplasms and use the dirty carcinoma terminology if the cells are atypical and there's submucosal invasion. No matter what, these are very indolent lesions, and most of them are perfectly benign. Here's why colleagues wanted to call them cancer. They're composed of these angulated glands. They're below the surface, generally an uninflamed oxyntic mucosa, and you can see that there are parietal cells intercalated amongst the cells that look like chief cells. Whether they're entrapped or an integral part of the lesion is not clear to me. They may just be entrapped, but they're there. Here's higher magnification, and you can see this little parietal cell here. All right, this is a Ki67 stain, and really it's scarcely staining the lesion at all, is mostly present in the proliferation zone of the adjoining gastric mucosa. Here's one that's kind of weird. It's mostly chief cells, and it looks like it's arisen in a patient with autoimmune gastritis. This is in the gastric body, and the parietal cells are all gone. And here's this one at higher magnification. And this is a different example, and this is a PAS Alcian blue stain, just to show you that these things don't have any mucin in them. And they're different from pyloric gland adenoma. This is a MUC5 stain. It's negative in the lesion with an internal control, and these do stain with MUC6. If you get yourself a synaptophysin stain because you think you're looking at a neuroendocrine tumor, it can be a fooler and it can be quite strong, but chromogranin will be negative. So I used to be quite naive and really was not convinced that any of them could possibly have any malignant features. But over the years, I've seen ones like this with more nuclear atypia and then slipping down into the submucosa, as in this case. And here it is at higher magnification. Now, if anybody in the group isn't used to telling apart incomplete and complete intestinal metaplasia, I will show you. It's an interesting thing because epidemiologically in high-risk populations, incomplete intestinal metaplasia at first screening is more likely to progress, so you can set patients in different surveillance categories by typing it. It might not work very well in the population that we serve here in the US, but it seems to be of some value in other populations. Here's the difference. Incomplete intestinal metaplasia is sort of stomach, and it has incompletely transformed into small bowel. So you see foveolar mucin in cells, and then in between those cells, you see goblet cells. The complete type is recapitulating small intestine or large intestine completely, and there's a brush border punctuated by goblet cells. I threw in a PAS Alcian blue on the right to illustrate the same thing. Of course, this is what normal small intestine looks like, and on the right you can see a nice brush border, and then between the goblet cells you can see cells that are absorptive. And this is, of course, the classic incomplete intestinal metaplasia that you see in Barrett's esophagus. And one last kiss goodbye to incomplete intestinal metaplasia versus complete. Let's go to the small bowel. There's not much real estate that we get to see much. There's not much dysplasia. And what you have to worry about is colonization of the small intestinal mucosa from other types of tumors. And it can very closely mimic intraepithelial neoplasia. So this is a patient with Crohn's disease. And of course, there's always lots of inflammation in the ileum. You can see pyloric metaplasia here, or stomach glands from cycles of damage and repair. And over here, there's some high-grade dysplasia, and you can see more of that there. Look at that abrupt transition like we've been talking about between dysplastic and non-dysplastic glands. And notice that this gland has actually taken on a sort of foveolar differentiation from all that damage and repair. The main thing in the small bowel is that it's treacherous. Um, Metastases are so common and they can colonize the surface, and metastases outnumber primary lesions by twofold. So, most things are going to be metastases. In this situation, if you have an immunohistochemistry lab, that can save the day. If you don't, good morphology skills can sometimes help you. All right, so this is just a sarcomatoid carcinoma that spread to the small bowel. Okay, fine. It was, I think, from the kidney. And what I'm trying to show you is that even sarcomatoid carcinomas with weird characteristics can actually colonize the surface. Obviously, you're never going to mistake this for an intraepithelial neoplasia lesion. It's just fascinating. This, on the other hand, is colon cancer that's metastasized to the small bowel. And you can see how a naive colleague could think that this was a precursor lesion. And look at these abrupt transitions. So it does a lot of things that precursor lesions do. So pretty scary. Here's higher magnification of colon cancer colonizing the small bowel epithelium. So here's reactive small bowel. Here's where this metastasis has just taken over the surface. Immunohistochemistry can be helpful. This is a CK7, which is negative and not infrequently positive in small bowel primaries away from the ampulla. And this is a CK20, which of course is more characteristic of colon differentiation. Nowadays, people use SAT-B2, but it's not perfect either. Here's the scary thing. Not that infrequently, pancreatobiliary type carcinomas can be seen colonizing up in the ampulla, or a primary ampullary carcinoma can colonize more at the surface. So at first blush, this gland is dull. So is this one. So is this one. Oh, but this is the gland that lives there. This is the very subtle, sneaky pancreatobiliary carcinoma that's just kind of slipping up into the surface. Here we are at higher magnification. Look at this abrupt transition here. This looks very different from the biliary type glands that live there, but if you're not onto this, it can really fool you. Here's another example of pancreatobiliary carcinoma colonizing up into the small intestine. And here it is at high magnification. This is pretty clearly malignant, but look at this abrupt transition as this epithelium takes over the native small intestinal epithelium. In this particular case, we were very lucky because there's loss of DPC4 or SMAD4, which is seen in about 60% of pancreatobiliary carcinomas. Down in the colon, of course, the big issue is dysplasia associated with inflammatory bowel disease. I think we all struggle with this. And of course, it was classically defined as adenoma, like way back in 1983. This is Dr. Riddell's landmark paper. But many observers even then noted that there were variant patterns. And over time, these variant patterns began to be described. And of course, I think everybody's aware of this paper by Choi and his colleagues, and he talked about variant patterns of colitis associated dysplasia. People also started to notice unusual serrated changes. This was noticed years ago, actually, by John Goldblum and his colleagues. And then later on, we noticed the same changes, and they seem to track very well with colorectal dysplasia. Of course, this study that we published a few years back was a little bit limited because it was retrospective. All right, so I think all of us are okay recognizing a case like this as colitis associated high grade dysplasia. It shows some of the same things that we would see in a colorectal adenoma, namely this loss of nuclear polarity here and here. This particular case, actually on P53, has a null pattern, which means complete loss. I'm sure many of you are familiar with it, if not all of you. And of course, this is because you have biallelic inactivation of the TP53 gene. So there is no P53 around to teach the cells to grow up properly. All right, but then more recently, colleagues have come up with the term non-conventional dysplasia, and of course that was further expanded upon by the Choi paper I noticed. And they came up with a lot of categories that probably didn't add much, like, too many Paneth cells, not very many goblet cells. But hypermucinous was really important because these are subtle and people tended to overlook these lesions. The colleagues also noticed that there were some serrated type things. I would argue that they were just seeing serrated polyps that happened to arise in patients with inflammatory bowel disease. But this is that so-called hypermucinous dysplasia, and it's really quite subtle. It reminds me a little bit of the gastric foveolar dysplasia that we saw earlier. The nuclei are hyperchromatic, but they're not all that big. But if you study them compared to other nuclei in adjoining biopsies, they will be darker and a bit bigger. Here's this area at higher magnification, and notice that the mucin is just a really peculiar color that you wouldn't expect. Mercifully, if you need a little hand holding, these often show strong point mutation staining on P53. There's something called serrated epithelial change, in which you see distorted architecture without dysplasia, like in the hypermucinous dysplasia, very different from serrated polyps. The crypts in serrated epithelial change lose their orientation to the lumen. They're not perpendicular to the muscularis mucosae, and they often don't reach the muscularis mucosae. The serrations are kind of subtle. The goblet cells are very distended and enlarged, and you see these enlarged goblet cells at the base of the crypts. It's very goblet cell rich, very different from typical hyperplastic polyps or sessile serrated adenoma polyp lesion, whatever your favorite term is. And the cool thing about serrated epithelial change, the way we've defined it, is in fact half the time it has TP53 mutations. You will not see the point mutation pattern of staining on immunohistochemical staining. And when we took patients who had SEC and dysplasia and cancer, the same P53 mutations were present through all of the sequence of events. And it's probably the field effect that was noted by scientists who don't actually have much of a chance to look at slides. And this is a paper that described this field cancerization some time ago. So this is an example of serrated epithelial change. And on the right, you have some typical dysplasia, but over here is your really weird architecture, these giant fat goblet cells, and then this kind of subtle serration. And here it is at higher magnification. Here is this peculiar serrated epithelial change, and here's more typical dysplasia. Yet another example, this one has a better appearance of serrations. And of course, this is the same patient, and there was some conventional appearing dysplasia. So just to sort of compare and contrast, a hyperplastic polyp or a sessile serrated adenoma lesion, whatever you want to call it, basically has preserved orientation. You can draw a line from the muscularis mucosae to the lumen. This, of course, is a hot mess in serrated epithelial change. And here's just another example with this serrated epithelial change here, and then some typical dysplasia there. So I would argue that the dysplasia here looks somewhat serrated, but I will understand completely if you disagree with me. In this particular case, once again, we see the null pattern. All right, so we're going to have a nice beauty contest, and you can see this nice example with this hypermucinous dysplasia here, more typical dysplasia, more hypermucinous dysplasia at high magnification. And now on the lower panel, we have some serrated epithelial change at the bottom compared to hypermucinous dysplasia, and at super high magnification, serrated epithelial change and hypermucinous dysplasia. So they are a bit different. All right. Of course, treatment has changed over time, and now our endoscopy colleagues are looking for lesions that they can see and remove rather than doing radical surgery as soon as a patient has dysplasia. The anus is really amazing. And we are all tired of the last classification that was published a long time ago. Let's look at some other cool stuff. All right, here we go. So there's something you can find called papillary immature squamous metaplasia, and our GYN colleagues figured this out a long time ago. But GI, we're a little slow. We're finally getting there, and we've noticed this strange thing that looks like a high-grade squamous intraepithelial lesion when you first pop down the slide, but they're basically like grade 1 half. They don't have mitoses. P16 is negative. So let's take a look. So those of you who are still awake will notice that this looks awful, but then it looks like we have that surface of anal transitional mucosa that almost looks columnar, and it's just thick. Okay, and these are associated with human papillomavirus 6 and 11, and they really aren't likely to progress. So my former colleague at Johns Hopkins also noticed some anal columnar lesions that look very analogous to cervical lesions, and they are HPV driven or HPV dependent, whatever terminology. I guess that's GYN terminology, and they look a little bit like cervical gastric type lesions, except those actually aren't associated with HPV, but this is a minor detail. So Dr. Voltaggio is on the left, and a senior gynecologic pathologist, Dr. Ranette, is there on the right with her dogs that she enjoys. And this is one of these lesions. Let me move my face. And you can see that this is right at the anal transitional zone. There's a little bit of squamous here. There's a little bit of colonic here. And then there's this lesion that, oops, I have to admit, I have misdiagnosed these as tubulovillous adenomas. I hope you'll forgive me, but this is one. But then as you look around, you start to say, there aren't as many goblet cells as I'd like, and what's this weird mucin? And that's your clue to get yourself some immunohistochemical stains. And this is cytokeratin 7, oops. And this is cytokeratin 20, And if you're lucky enough to have the in situ hybridization for high risk HPV, it's positive. But if you don't have it, these are just really positive for P16. And it just gets stranger and stranger. There's so many things that the GYN people have known about for years that we're just figuring out in the anus, such as stratified mucinous intraepithelial lesion and adenoid basal carcinoma. A really cool one has actually been described by a man who is now my colleague. His name is Eric Williams. And he found that there were these weird basaloid-like carcinomas or cylindroma-like carcinomas in the anus, and they had the same mutation, in fact, as patients with familial cylindroma syndrome. These are HPV associated. On the other hand, if you look at the head and neck ones, they often are not. So kind of interesting. And here's one of these lesions in the anus. You can see that it's arisen right at the transition zone. I did synaptophysin on a biopsy I saw because I was worried it could be neuroendocrine carcinoma. But then it has this very, very strange pattern that really does look like a cylindroma or an adenoid cystic carcinoma. So just fascinating. Here's this one at higher magnification. And this happens to be the P16. Wow. Of course, this is P40, which is strongly positive. Synaptophysin was negative. So very interesting tumors we're starting to see. I know I've started to see some other things that we thought were just in the vulva in the anal area. So the story will continue. So we've discussed some tips for addressing reactive versus dysplastic in columnar lesions of the esophagus and stomach, a bit about squamous cancer, precursors. We've talked a little bit about metastases to the small bowel and their mimicry of in situ lesions. We commented a little bit about classification and treatment of stomach and colorectal dysplasia. And of course, we've enjoyed some newly recognized anal lesions. And with that, I thank you.
So we are all done with our first talk. I must say that this is intellectually very stimulating, And it re-emphasizes the fact that we all need to, including myself first, that we all need to study more so that we know what is out there and how the people are recognizing different and subtle changes, so that we can also start recognizing those. So with that, we will proceed with our next lecture, and the topic for the next lecture by Dr. Elizabeth Montgomery is "Oops, we were in the lesion and other mishaps over the years." So let's proceed with the second lecture.
Hi, everybody. I'm still Elizabeth Montgomery. I'm a pathologist at the University of Miami in the US. And let me share my screen and then share some fun cases. Here we go. All right, so I'm going to show you my mistakes over the years, and I'll show you other people's mistakes too, but some of these are mine. Oops, we were definitely in the lesion, and other mishaps over the years. All right, so let me show you some dumb thing I did. So imaging studies from an 80-year-old man showed a large, solitary, highly vascularized mass in his liver. No other anatomic structures were affected, according to the surgeon and the radiologist. So we were sent slides, and this was some time ago. I would not do this particular stupid thing again, but I did it. An H&E section and a CD34 stain from a needle biopsy of the liver lesion were received. A keratin stain was reported as negative. So here we have this nice imaging study, and it looks like we have liver and then this thing here. So you can see it quite nicely. And here it is on another view. And here's one of the slides. It's a little fuzzy because this is actually a kind of old case. And so you can see some cells that have vacuoles, and you can see some blood vessels, and they're kind of epithelioid. Here's another image. Again, you can see these intracytoplasmic vacuoles. Very, very nice. And here was the CD34, which shows an interesting membranous type of staining. So dodo brain here diagnosed this as epithelioid hemangioendothelioma, which was absolutely wrong. And here's what happened. So at operation, the surgeon resected a 15-centimeter mass. It involved the gastric muscularis propria, so stomach, and the liver was completely uninvolved. And of course, the lesion was strongly KIT or CD117 positive, and of course, CD34 positive, and was clearly a gastrointestinal stromal tumor. Well, obviously, I've had the joy of calling up the surgeon and telling him what happened. He took it very well, and luckily nothing had been done to the patient that would otherwise not have happened. But do remember, anytime you receive a biopsy labeled abdominal mass or even a liver mass, because just metastasized to the liver, always think of it so you don't make a fool of yourself the way I did. Let's look at some more misadventures. Some of them are mine, some of them are other people's. So this is not my blooper, but let's look at a biopsy of a liver mass. So let's see, do we have any hepatic tissue? Yes, here's some hepatic tissue. Not sure what this is. And then there's this thing. Here's more of it. Here's more of it. Let's move me out of the way. And here is some more hepatic tissue. And here's the interface between the hepatic tissue and the mystery tissue. And I'm going to guess that some of you have recognized this, and some of you are chewing your nails. And here it is at higher magnification, and there are some rather atypical looking cells, but we have an internal size control. There are some neutrophils within the lesion. This is the same diagnosis, but I think a different case. And you can see a needle biopsy, again said to be from the liver, showing this lesion. And here it is at higher magnification. So do you want to be put out of your misery? And of course, this is just splenic tissue. And splenic tissue, when it's heterotopic tends to lose its white pulp. But if you want to do an immunohistochemical stain to take yourself out of your misery, CD8 does a good job because for whatever reason, the endothelial cells lining the spleen sinusoids co-express CD8, presumably to increase the crosstalk between the lymphoid system and the rest of the body. So there are all these lovely, these stained with CD8. So pretty cool. And you can see there's not a lot of CD8 in the hepatic tissue in the back of the biopsy. This happens to be another example, again, with a positive CD8 stain. So if there aren't very many bits of white pulp or lymphoid aggregates within your spleen, it's probably just a heterotopic little mini spleen. And I have to say, over the years, I've seen this a lot. It hasn't been my blooper, but boy, I can see how somebody would bloop. And the blooper that, or the mistake that people make is doing a massive workup for angiosarcoma. And you can see why, or for various lymphomas. All right, this is a biopsy of an ulcer of the duodenum. I didn't do this one either, but I certainly could have. So let's take a look. All right, so let's get a sense of the fragments. So this is supposed to be in the duodenum, but as you can see, there's a lot of gastric type lining to this. There's a lot of foveolar cells, but anytime you have injury to the small bowel, you'll see gastric foveolar type cells. And then there are these other pieces of mysterious tissue. And here's one of them at higher magnification. So I bet some of you are saying, what is this? Is this a hepatocellular lesion? Well, it certainly looks like it could be. So this patient, in fact, had a history of Crohn's disease, and the endoscopist noted that the tissue felt very, very firm when she was taking the biopsies. So let's get back. It definitely looks like it has hepatic differentiation, correct? And a colleague had done an arginase, and you can see that the arginase stain does confirm that there is hepatic differentiation in this tissue. I believe the colleague had also done a HepR, or hepatocyte-related antigen, and that was positive. And then the query was, oh my gosh, is this hepatocellular carcinoma pressing directly into the duodenum? So I did a special stain. I did a reticulin. And basically, that tells us that this is simply non-neoplastic hepatic tissue that was pressed up against the duodenum, and then the ulcer eroded into it. So, wow, very crazy case, but it's just hepatic tissue. Remember, of course, that sometimes colleagues really think they're in a needle biopsy in a lesion and they're not there, but remember that structures can erode. All right, this was almost my blooper, but I was saved by sharing it with a smart colleague. Rectal mass, that was the history provided. Okay, so here are the tissue fragments, and I'm sure that you can see some colonic mucosa here. And then there's this stuff, and then, that looks interesting, and that looks interesting. So let's take a look. So here is interesting area number 1, composed of these very strange looking glands. So I thought, oh, I'm so clever. This just looks like an anal duct carcinoma that's ulcerated. Oh, I'm just so clever. No, not so much. Here it is at higher magnification, and no, I am not clever at all. And what is this second population of cells doing here? And these cells look atypical, and what the heck is going on? So I was super confused, realized I should probably get a confirmatory stain before I diagnosed anal duct carcinoma. So I got myself a cytokeratin 7. And there was a moment when I was about to put out a report, but then these second layers of cells talked to me and told me I should be careful. It must be anal duct carcinoma, but there's something wrong. And then I scratched my head and I got an NKX 3.1, which, as you guys know, is a very nice marker for prostate lesions and prostate carcinoma. And then I was still confused because there are all these cells that are staining, But then there are other cells that aren't, and then this outer layer doesn't seem to be staining. So I kept scratching my head and then got myself a GATA3. And I've been taking these photos from slightly different areas, but the GATA3 is positive in some cells. Okay. What's going on? Well, a minor detail that the surgeon didn't bother to mention is that the patient had a history of prostate cancer and had undergone radiation only to manage the prostate cancer. The strange tissue is radiated prostate tissue. And of course, normal prostate basal cells express GATA3. Now, of course, I was oblivious to all of this stuff. And luckily, one of my urologic pathology colleagues, Alexander Kravchenko, who's really quite a force in urologic pathology, taught me that he sometimes sees this. And there are actually other people who have seen this phenomenon. So here's that area with the two different layers. And again, here's our NKX 3.1. And yes, that is highlighting prostate epithelium, but then the GATA3 is hitting the basal layer. So as a comparison and contrast, here is the real anal duct carcinoma, and it can often have tiny tubules, but of course there's not a second layer. And that, of course, is the big clue. Another interesting thing about anal duct carcinoma is you get these tubules underneath the surface, and sometimes you'll see pagetoid extension into the surface. And of course, in this area, it eroded, so it actually more or less reaches the surface. Of course, anal duct carcinomas do express CK7. On the left, I'm just showing you a general field, and on the right, I'm showing you some pagetoid extension from that anal duct carcinoma. So the diagnosis, of course, in the rectal mass that I just showed you is simply prostate tissue with radiation-associated changes. And in fact, some colleagues have reported this in this nice reference here that was in Annals of Diagnostic Pathology. And they reported it after seed brachytherapy and a similar phenomenon with a rectal ulcer. Obviously, if you mess this up and call it a colorectal carcinoma or an anal duct carcinoma, this is a terrible thing to do for the patient. All right, this case was diagnosed as squamous cell carcinoma in a 56-year-old man, and the patient presented for additional treatment. So let's take a look. Here it is. So here's this nice squamous cell carcinoma, and you can see it looks like it's sort of got a verrucous appearance. So let's keep looking and see if we see anything else. And here it is at higher magnification. And there seems to be a nice basal layer and then other stuff above. And then there's this stuff here. And there's an awful lot of deep inflammation. Okay. So this is higher magnification showing what I just showed. And those of you who are awake are probably noticing that there are an awful lot of plasma cells down here underneath this squamous mucosa. Oh boy, there are really a lot of them. Now let's take a look here at the top. So we were in perianal skin, so you'll notice that there's an arrow indicating a melanocytic process. And of course, melanocytic processes are very common right around the anal opening, and you can see them indicated at least one by the arrow. Here, it looks like here's another one. All right, so what's going on here? Oops, it's a sexually transmitted infection, or STI. And this happens to be a treponema pallidum immunohistochemical stain. And I know I find for area lesions in this area, it's much better to use the red chromogen than the traditional diaminobenzidine chromogen. And in fact, this is not syphilis at all. You can see that this is a melanocytic process, and then all of these little tentacles of red are in fact the syphilis organisms. So I have to say, I've seen papers in which people publish positive syphilis stains, and all they're showing are the melanocytic processes, and they had used the brown chromogen. But it's very nice in this particular case. So let's see, my computer's acting up. Momentito, let me get it going. All right, so this was a condyloma latum. So of course, a condyloma latum is part of syphilis. Of course, we call it Louis also. It's caused by Treponema pallidum. It's a sexually transmitted infectious disease that you'll recall is characterized by primary, secondary, and tertiary stages. The first stage, nobody really notices. The patient gets a chancre, which is painless and firm and red at the site of inoculation, and it heals in a few weeks. But of course, if this is in your anal canal or in your distal rectum, you won't notice it. It will be completely inapparent to the patient. Then you have a secondary change, which is characterized by a maculopapular skin rash that results from the spirochetes multiplying in the skin and mucous membranes, and that's 2 to 10 weeks after the first inoculation. Condylomata lata or condyloma latum are these broad raised flat plaques, and they're in the secondary changes, in the secondary stage, and they really do mimic human papillomavirus or even cancer. So you see acanthosis, erosions, elongation of the reedy ridges, exocytosis with neutrophils, so a lot of overlap with highly differentiated carcinomas, spongiosis, that just means edema. And if you're lucky and your biopsy's deep, you'll get to see the endothelial swelling and proliferation. Now, in contrast, let's look at the real verrucous carcinoma. Let me move my ugly face. And you can see there's a bit of an inflammatory background, but this only went a little ways. It didn't go very deep. And so you'll see these areas that have this abnormal keratinization, sometimes neutrophils. Here's this pushing front. Notice that at lower power, the inflammatory backdrop is much less, and you'll have areas where you lose the basal layer, but it's subtle and sneaky. And of course, if your biopsy is superficial, you can't always do the job. All right, a 68-year-old woman noticed a lesion near her anal opening and presented to the clinic for a biopsy. This is an important thing. You do not want to screw this up. If you live in the United States, you will get sued. If you live elsewhere, you'll just be a terrible person. All right, so this is the lesion. Let me move my face away. Whoops, I don't want to make it bigger. Let me move it away. And here it is. Okay, so basaloid squamous cell carcinoma, next case, right? No, 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 no. Bad idea. Let's keep looking. And I'm going to make this smaller. So here it is at higher magnification. So kind of think about how this looks for a minute and have another thought. What if this were on somebody's arm or back? What would you be thinking? Well, you would be thinking of basal cell carcinoma. And basal cell carcinoma usually occurs in sun-exposed skin. It can be a huge diagnostic pitfall if it's in the anus. You can get some help from your favorite dermatopathologist, but if you have an immunohistochemical lab, you can add yourself a P16, which will be negative, and you can add yourself an EpCAM, which is also called BEREP4, and that usually shows strong staining. Of course, basaloid squamous cell carcinomas can show some EpCAM or BEREP4 staining, but it's not usually strong like what you see in a skin type basal cell carcinoma. Don't know why, with the lack of sun exposure, that these can be in the anal area, but they can. Do not screw this up. You will not serve the patient well. So this is a nice example of BEREP4 in one of these perianal basal cell carcinomas of the type of skin, not a basaloid squamous cell carcinoma. So I've kind of done a beauty contest here. On the right, we have a basal cell carcinoma, and you really do see that peripheral palisading of the nuclei, and this is your basaloid squamous cell carcinoma, which lacks it. But you really have to be on your toes and not mess that up. All right, anal mass was removed or needle biopsied from a 38-year-old woman. So now I'm showing you the Miami vibe. Hopefully you don't see this too much outside the US, but I thought you would find this case enjoyable. So anal mass removed from a 38-year-old woman. Here it is. So let's see, what do we know? Well, there's some skin. So you know already that it's superficial. Here's some more skin here. So somebody just put a needle into this thing that was by this woman's anal area and was very easy to get to. Let's take another look. Here's another spot. And those of you who do derm probably know what this is, but for other people, this might be hard. So is this a liposarcoma? Too bad we're not talking. And of course, it's not a liposarcoma, and I've given you some clues. I put a blood vessel here, and you can see the endothelial cells, so that's your internal size control. And then we can look at the nuclei in this process, and they're just not that big. So here they are. It has a lot of these cells that look like lipoblast, but if this were a myxoid liposarcoma, the type that has tiny nuclei, we would expect a rich vascular pattern, and we don't see that. I had to hunt to find a vessel for an internal size control. Here's another one, but it's certainly not the delicate arborizing type of vessels that we would see in a myxoid liposarcoma. And it doesn't have the large atypical hyperchromatic cells that we would expect in a well-differentiated liposarcoma. And this is a silicon granuloma. So I live in Miami, and there are a lot of people who just aren't happy with their appearance, and they want to do things to change their appearance. So they get their injections of this and that all over their bodies, including in their bottoms, to make their buttocks look larger. In contrast to liposarcomas, silicon granulomas are usually subcutaneous after augmentation to augment whatever structure is being injected. You can also see a similar tissue reaction around the mouths of people who want to have plumper lips. And of course, the really obvious place where you might see this sort of thing is around an area where a patient had breast augmentation. There are also reports of do-it-yourself or DIY attempts at penis enlargement that have produced similar results, and there's some fun references listed below. So if you're struggling, and when you get one of these, you can always get yourself your favorite histiocyte marker. This happens to be a CD68 on the left, and it's showing those cells. Of course, the vacuoles of the silicon push away the cytoplasm, so you see kind of a ring of CD68 in several of the cells, such as this one. So nice example of a silicon granuloma in a patient who'd had silicon injected into her buttocks to make them plumper. All right, so let's have a beauty contest. On the left, we have an atypical lipomatous tumor or well-differentiated liposarcoma with a large hyperchromatic nucleus. And on the right, we have our friend, the silicon granuloma. Another liver biopsy. I didn't do this one, but oh boy, could I, and I hope I never do. All right, so this is a case that came in diagnosed as hepatocellular carcinoma. This is a liver needle biopsy. You can see some hepatocytes here, and then there's this lesion. So hopefully some of you recognize it. So this particular one I have not done, but boy. All right, this is another example of the same kind of lesion. And this is an HMB45 stain. So, of course, this is a pecoma. This happens to be a separate case. This is a renal pecoma. So you can see it's a little bit more solid here, whereas in this part it has more fat as a component of it. So let's talk a moment about the pecoma club. And of course, pecoma means perivascular epithelioid cell oma or tumor. So these are neoplasms with this so-called perivascular epithelioid cell differentiation, except nobody really knows what that cell is. And of course, these are mesenchymal tumors that are composed of histologically and immunohistochemically distinctive cells with this peculiar differentiation. And we really don't know normal counterparts. So these are some of the entities that we've all learned about over the years. And the classic, of course, is angiomyolipoma. It can have all sorts of variations on the theme. You can see also lymphangiomatosis of sinuses. There used to be something called the clear cell sugar tumor of lung. Also, there's lymphangioliomyomatosis, and it goes on and on and on. And of course, there's PCOMA not otherwise specified. So PCOMAs can have epithelioid cells or they can have spindle cells. Sometimes the cytoplasm's clear, sometimes it's granular. There's often a cuffing around vessels. And of course, there's the classic myomelanocytic immunophenotype. If you do ultrastructure, you can find melanosomes. And of course, there's a relationship to the tuberous sclerosis complex or the TSC complex with TSC gene alterations. And these tumors respond to the mTOR or mechanistic target of rapamycin inhibitors or the rapalogs, such as rapamycin and temsirolimus and everolimus, et cetera, et cetera. But there's a separate variant that has TFE3 gene rearrangements. And this is kind of a collage of all the different appearances that you can see in these PCOMAs. And if you're kind of aware of them and they pop up in the liver or in the kidney, you're going to say, boom, aha, let's do this. So, of course, here's the immunostaining spectrum. And I apologize, on the upper left is an HMB45. And here it is at higher magnification. All right, so the commonest of the PCOMAs is the angiomyolipoma, and that is seen still very infrequently, and it's seen in about 1% of renal cells or of renal tumors. If you take all the PCOMAs in the kidney, up to 20% are associated with the tuberous sclerosis complex. But if you take patients with tuberous sclerosis in the brain, then you will find that quite a few of them have kidney lesions. This is a lady's lesion. Normally, the age at presentation is 50, but it's younger in patients who have tuberous sclerosis. And then, of course, you can see these things really just about anywhere. And here's just a nice example of a lesion that has more of an angiomyolipoma phenotype. Notice that on the upper right, this guy, boy, you could get mistaken for all sorts of things. This, on the other hand, is one of the weirdo TFE3 rearranged ones. So this was a colon polyp actually from a child that I got. These are a bit different. They don't have muscle marker expression. They do continue to express melanocytic markers, and they're unassociated with the TSC genes. And here's this one at higher magnification. I have a confession. When I got this, I first thought it was an alveolar soft part sarcoma. No, 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 no. And here it is at higher magnification. On the upper right, you can see the HMB45, and then you can see the TFE3, which of course you could also have in an alveolar soft part sarcoma. However, you also wouldn't have HMB45 staining in an alveolar soft part sarcoma. All right, pitfall alert. If you use immunostaining for MDM2, some fat predominant angiomyolipomas or PCOMAs do show staining. Luckily, the in situ hybridization will be negative. And this is just pulled right out of a paper by Rebecca Ash Kendrick with the senior author Ashley Chimino Matthews. And you can see that in this PCOMA, this angiomyolipoma, there is definitely MDM2 immunohistochemical staining of the nuclei. So kind of a scary thought. This is another hepatic one. This would meet criteria for malignancy, but you could really easily get fooled into considering a peculiar liposarcoma in this particular example. And here it is at higher magnification. And in fact, a colleague had done an MDM2 on this and almost gone down the garden path. That time I rescued the person, but I could have been the one rescued. And here's another field. Just also remember, this is just liver. And notice this is a cirrhotic liver, and this was from an explant in a patient who underwent a liver transplant. And I don't know about you, but I could certainly get tricked if the needle biopsy of the liver lesion hit the adrenal. And I have seen other colleagues make this mistake. It's not one I've done yet, but don't put it past me. And you can see how this could really send you down the garden path. Oh my gosh, is this metastatic renal cell carcinoma? You can imagine all the foolish things you could come up with. And this is just pure adrenal, just to remind us, don't forget, they might think they're biopsying the liver, and yet you get adrenal, or thinking they're biopsying the kidney, and yet you get adrenal. Okay, biopsy of another liver mass. What's going on here? Well, there's a cool thing here, and then what the heck is this? So let's keep looking. Oh, what on earth is that? I have a feeling the patient coughed after the biopsy, and it's lung tissue that accidentally made it onto the slide. The elastic tissue in the background is here, and this probably is a reflection of what the actual mass was, which was segmental atrophy of the liver. And this is a peculiar pseudotumor that you can find in patients. It may track with vascular insufficiency, but I'm not sure that's really been proven. But this is a nice example. At first, you have preservation of the portal triads, but you start to lose tissue between them. And over time, the process fills in with elastic tissue and turns into a pseudotumor, and it's usually subcapsular. And these images are from a nice paper that was published some time ago by Ator Singhi, first author, with Michael Torbenson as the last author. Here's an example from my practice. Now, something's gone wrong with the label, but what I'm trying to tell you is that this is the capsule. And then here's this area that just looks really weird. And as you get to higher magnification, you can see that it's all elastotic, and that's just elastotic tissue. Lovely elastosis in segmental atrophy. All right, this is an earlier example of segmental atrophy, and you can see you're starting to get this injury, but the bile ducts are spared, and then there's just this peculiar pattern of fibrosis between where they are and then where the rest of the liver parenchyma is. And here that is at higher magnification with somewhat subtle elastic, but here you can see it nicely on an elastic stain. All right, we're going to circle back to my original dum-dum error and talk a little bit about the real epithelioid hemangioendothelioma. So back when our forefathers didn't have the tools that we have now and were studying this, they wondered if this was a cancer in the liver, a weird sclerosing carcinoma of the liver. In the lung, it had another name, IVBAT, intravascular bronchoalveolar tumor, and many, many articles later, the endothelial nature was uncovered. It was definitively recognized as a vascular neoplasm in soft tissue by Sharon Weiss and Franz Enzinger, and of course, ultrastructure was the molecular of its day. So, in the liver, they're rare. They tend to have an infiltrative growth pattern. Sometimes they can metastasize out of the liver. Most patients don't die of hepatic epithelioid hemangioendothelioma, and nowadays they get liver transplants for it. If you use the nice risk stratification scheme that was developed by Andrea Dayrup some time ago, it really doesn't work for the liver ones. All right, so this is an example of an epithelioid hemangioendothelioma of the liver on a needle biopsy, and it looks like nothing. And it's super infiltrative. It's not well marginated. So you'll recall that the GI stromal tumor that I showed you at the beginning was exquisitely well marginated. Oops. And here it is at higher magnification. Very easy to overlook. It almost looks like fibrosis. And then as you look harder, here are the famous blister cells, which have intracytoplasmic alumina, but erythrocytes probably don't really flow through them, but we do sometimes see erythrocytes in them that are probably pressed there, but I honestly don't know. But it looks very different from what I showed you at the beginning. And here is a CD34, and yeah, it's staining the cells, but it's a little different from the strong staining we saw in the GI stromal tumor at the beginning. One thing that's really cool on CD34 is that sometimes you'll get this accentuation of these intracytoplasmic lumina in epithelioid hemangioendothelioma of the liver. And this is a CD31, also highlighting this very infiltrative lesion. Do remember with CD31 that histiocytes can stain, so don't go down that garden path. This is the kind of case that's the reason that our forefathers thought these were sclerosing cholangiocarcinomas. If I wasn't thinking, I would sign this out as a cholangiocarcinoma any day of the week. But it's not quite right. The nuclei are a little bit more monotonous. Here are our little intracytoplasmic lumina, and the background is a little bit more chondroid. Of course, this is if you think of it. Here's that one on higher magnification, and here are those beautiful blisters. So they don't really look like mucin vacuoles. They're just sort of peculiar, and they're more crisply delineated than a mucin vacuole might be. Okay, and now we have ERG. So this is ERG on the one I just showed you. This is CAM 5.2 keratin, and of course the entrapped hepatocytes stain more, but do remember that these epithelioid vascular tumors do often express keratin. It's usually not as strong as in real epithelial cells. But a key feature is this infiltrative growth pattern, and this was from an explant performed for a transplant to get the patient a new liver. And you can really see how tricky this can be if you were to have a needle biopsy that went here instead of here. And of course, epithelioid hemangioendothelioma does have a characteristic genetic alteration, and I think most of us are quite aware of it. So you can see this nice translocation paper from 2001. And then 10 years later, the gene was cloned actually by two different groups at the same time. And there is this fusion with WWTR1 and CAMPTA1. And of course, now we have an immunohistochemical stain that highlights the CAMPTA1. So we see nuclear staining in most cases. And it's a wonderful diagnostic marker. And it's wonderful for cytology specimens or teeny tiny biopsies. I've also learned over the years that sometimes epithelioid hemangioendothelioma can become very spindly. So for situations like this, it can really be very helpful to have this CAMPTA1 immunohistochemical stain, and it's a good crisp nuclear stain, as in this case. All right, so there are many hepatic epithelioid hemangioendotheliomas that are primary, but occasionally they do reflect spread from other sites, and most of them are indolent and grow slowly. So for a while, there was a move to talk about this variant of epithelioid hemangioendothelioma that had an alternate fusion of YAP1 and TFE3. They've been identified in lesions that lack CAMPTA1 fusions, but with more evidence, there's a move to regard them instead as YAP1 TFE3 fused hemangioendothelioma as its own thing. Why is that? Well, because they look a little bit different. They tend to be more vasoformative than the classic epithelioid hemangioendothelioma. This is a very nice paper from a couple of years ago that kind of proposes that name change and discusses these tumors in more detail. All right, palate cleanser before we finish off. Surgical resection following an endoscopic resection with a positive margin. Here it is. So there's no tumor here, but what you can see here is some mucosa on the surface. And then you can see this weird stuff here, this mass. Here it is. You can see India ink tattoo that the endoscopist had initially injected. And then there's this just strange business here. It almost looks like amyloid, but why does the patient suddenly have an amyloid tumor? Here it is at higher magnification, and in fact, this is mucosal lifting agent that was injected before the first endoscopic procedure was done to make it easy for the gastroenterologist to lift up the lesion. And my colleague, Mariam Harad Pajou, described this with Christina Arnold as the last author, and they noticed that this stuff looked a bit like other things, but it's actually quite different. So don't get fooled by mucosal lifting agents. So the trade name of the one that's been an issue is ORISE in the United States. And of course, it's been used to elevate mucosal lesions and resect beneath them in endoscopic procedures. But there can be a very dramatic tumor forming foreign body response. In the US, the Food and Drug Administration took this product off the market in November of 22. So we'll stop seeing this, at least in the US, but I imagine we'll see the persistent lesions over time. So this is a colon injection. So you can see there's this goopy stuff that's been injected into the submucosa to take out this sessile serrated adenoma. And if you want to use the word lesion or polyp, feel free, but you can see this goopy stuff that's injected. Here it is at higher magnification and still higher magnification. And then this is what happens when you go back. There's this massive foreign body response. In this case, there's still residual lesion in this resection. And look how dramatic this stuff can be. And it can really make quite a mass, which is why it got taken off the market. And here we are at higher magnification. All right. So the last theme is that colonization is bad. I think most people would say that anyway, but I'm not talking about colonizing countries. I'm talking about colonizing mucosa. And of course, these are some papers that describe that. So, of course, small bowel adenocarcinomas are very, very likely to be colonized. And I showed you examples of those already. We pointed out that metastases outnumber primaries 2 to 1. And what are some features favoring metastatic versus direct spread? Or, I mean, direct spread from outside. The presence of multiple lesions, the absence of a precursor, a bottom heavy appearance, and a lack of ulceration. And of course, these things are just logical. I showed you this case of the sarcomatoid carcinoma sneaking up into the small bowel and colonizing the surface. I showed you also this amazing colon carcinoma colonizing the small bowel and discussed it in some detail. And here it is at higher magnification. And here's the pertinent immunohistochemistry. And of course, small bowel adenocarcinomas are often double positive for 7 and 20, or even lose both. And then I showed you these crazy cases of pancreatic cancer colonizing the ampulla. And here's that one that I shared. Here's the other one, or actually this is a different one, I believe, in which we have pancreas cancer colonizing up into the small bowel. And here this is at higher magnification. And this is fascinating because it's really hard to pick it out on this particular slide. But then on this SMAD4, we can see it very, very nicely. But there are other sites besides the small bowel that can be colonized. So let me show you some. So this is an amazing case. This is a case of metastatic pancreas cancer to the liver. You don't have to be very good to see this, but you do have to be a little bit good to spot this, where the bile duct has been colonized. So let's take a look at that at higher magnification. Check it out. So this is a regular bile duct looking normal. This bile duct has been colonized by the metastatic pancreas adenocarcinoma. And in this particular case, you can see that on the DPC4 or SMAD4 with loss in this one and retention in this fake or in the real bile duct. And here that is at higher magnification, the cancerized bile duct, the real bile duct, and actually a few more cells have popped up in this field. This is another example of pancreas cancer. This time it's colonizing gastric mucosa. It's really, really wicked. All right, I'm going to close with a case that I share whenever I can because it's so important. And this is a mistake that I made in 2005. And this was a small bowel biopsy from a 22-year-old boy or man. I guess he thinks he's a man, but I'm so old that he seems like a boy. And here it is. So, small bowel biopsy from a 22-year-old young man. And this was a cytokeratin 7 and a cytokeratin 20 was positive. Showed a few colleagues. And here's my report. Poorly differentiated carcinoma involving the small intestine. Please correlate with imaging studies to address the possibility of other disease sites. So my report was correct by the letter of the law, but I hadn't served the patient very well. And in fact, this resulted in a long delay. And eventually, the colleagues learned that this was metastatic embryonal carcinoma after really a substantial delay. Later on, I received this case. This is also an embryonal carcinoma that spread to the small bowel, and it's actually colonized the surface here. But luckily, by then, I had learned my lesson and diagnosed this correctly. Whew. You don't want to miss germ cell tumors, of course, because they're one of the few things that our oncology colleagues can really do a good job with. All right, another young male patient with a duodenal mass. This had been reported as Ewing sarcoma of the duodenum, and that exists. There's some small case series, and I know I just reviewed a paper from China with 25 cases, so you can get this. And here's the case. So it's a bulky mass in the small intestine, and it looks like it's coming from outside in. And then I draw your attention to this focus and this focus. And I'm sure that some of you are probably already onto this. And here it is at higher magnification. Never reaches the mucosa. And some of the cells look kind of like round blue cells, but it looks like the population is heterogeneous. So there are lymphocytes here, and then there are these large cells. Oh, that might be an eosinophil, but it's a little more pleomorphic than we would expect for a Ewing sarcoma. Another area. I hope some of you have figured out what this is. And then here's yet another area, and it has, here's a giant cell, histiocyte. I guess this is sort of a poorly formed granulomatous area. So it had been diagnosed as Ewing sarcoma, and at the time considered also part of primitive neuroectodermal tumor because CD99 was positive, and chemotherapy appropriate for Ewing sarcoma was introduced but was not producing a response. And then I had the chance to see this, and I'd already learned my lesson. Here's KIT in that tumor. And this is SAL4. And this is OCT4. So there you have it. So I'm sure all of you know what this is. And of course, this was a seminoma. And when they went back and did ultrasound and worked the patient up, a tiny testicular primary was detected. So lesson had been learned for me, and I guess after that by the other colleague. So in summary, when the findings in a needle biopsy look very strange, do consider the possibility that a different sample has been taken than the targeted sample. Don't ever forget to consider gastrointestinal stromal tumor in biopsies from the liver, whether it's metastatic disease or inaccurate interpretation of imaging or any abdominal mass. Always think of metastases if you're looking at biopsies from small intestinal masses. And of course, it won't happen much in your career, but don't let it slip by. If you see a malignant neoplasm from a young male in an odd location, do try to give the oncologist a thrill by at least considering a metastatic germ cell tumor. And I thank you very much. And with that, I close.
So, colleagues, we have finished our second lecture. Now, that was a wonderful depiction of humbleness, ethics, and knowledge, which so it further accentuates the fact that whenever you have something you are reviewing and it does not make sense or click, I think there are 2 3 options which everyone can adopt, or at least we all should remember to adopt in our own provided circumstances. Either look at it again, try to make it fit, or show it to a colleague, get an opinion, or if you can do more testing, I think that's always helpful. Again, and everyone can make a mistake. We all know and should remember. And that's, I think, one of the biggest messages from this second talk. So with that, we will take a break. So we will be back at 3 o'clock sharp to start the live session with Dr. Anil Parwani. So till that, stay safe and have lunch, and we will meet again. Um, Take care. Allah Hafiz. Good afternoon, everyone. Welcome back. Those of you who have joined us now, welcome to this 22nd Annual Shaukat Khanum Cancer Symposium. So we are halfway through to the pre-symposium workshop, and now I would like to welcome Dr. Anil Parwani, who will be giving us a talk. Dr. Parwani is a professor and vice chair and director of anatomical pathology at Ohio State University. He is also a director of pathology informatics and digital pathology. He is editor-in-chief of Diagnostic Pathology Journal. Dr. Parwani has a subspecialty interest in surgical pathology, viral vaccines, and immunology, and he's an authority figure and huge name in pathology informatics. As we all know, anatomical pathology, um, actually artificial intelligence has made a tremendous progress in the field of pathology, and Dr. Parwani will be discussing the critical role of digital pathology and artificial intelligence in pathology diagnostic education and research. So Dr. Parwani, welcome. We are extremely grateful for you to have a live talk, to give us a live talk. So mic to you.
Thank you so much. Thank you for inviting me. It's an honor. Can you hear me?
Yes.
Okay, perfect. I'm going to share my screen. Okay, can you see the presentation?
Yes, Dr. Parwani.
All right, thank you so much. So I'm going to get started. So what I would like to do is discuss with you some of the advances that we've seen recently in digital pathology and AI, and how it's enhancing our diagnostic capabilities. It's helping us with education and research. So this is a new hospital that's being built on campus at Ohio State, 1.9 million square foot inpatient hospital, and 820 beds in private room settings. So this is going to be opening in 2026. And my office is somewhere behind this big building in the older building. So I would like to talk to you about digital pathology and AI and how it can improve our diagnostic accuracy, explain the role of digital pathology and AI in optimizing our workflows, and list situations where we can use these tools to enhance research, education, and facilitate collaboration between pathologists and clinical teams. So there are many, many technology advances in anatomical pathology, and it's really an exciting time to be a pathologist. So we have more automation, more structured data, genomic pipelines, pixel pipelines, ability to analyze images, and ability to use AI and large language models like ChatGPT. So in general, what is all this resulting is pipelines of knowledge, pipelines of data, which is converting into knowledge. And this is the knowledge age of anatomical pathology. Our reports are becoming more complex, right? So the information that I put in my report, the number of entities that we have to know about, continues to increase. So for example, this is the 2016 edition of the WHO book in GU. And if you look at a few years later, 6 years later, it's exploded in the number of pages, more emphasis on molecular and genomics. And I predict that in the next edition, there will be a lot of AI-based assays that will be used in surgical pathology. So, for example, these are oncocytic renal tumors and some of their differential diagnoses, and they can look very similar to each other. But we're discovering more and more new molecular information about this. How does digital pathology fit into this workflow, right? So as a pathologist, visual information is very central to our diagnoses, the way we do research, and the way we train residents and medical students. So essentially, what you're doing is the same thing. So this is an example of a viewer where I'm looking at a tumor, but it's recapitulating the work that I would do under a microscope. So once you have this microscope in a box, you have now created a powerful microscope or whole slide imaging. And once you can convert your glass slide into millions of pixels, you can start to apply computational pathology and AI. So where are we with this in terms of in the industry? Where are things going? So today we have automated, high-speed, high-resolution whole slide imaging systems. They can scan, you can load up to 1,000 slides in some of these machines and walk away. And it might take 1 to 2 minutes to get a high-resolution image with a resolution which is 0.25 microns per pixel. So up to 100 slides per hour, 2,000 slides per day at 40x resolution. How does that translate into it? And there are a number of devices out there. They could be as simple as a microscope with a camera attached to it, with a stage which scans the slide, or machines where you load 300, 360, 1,000 slides and you walk away. But as a GU pathologist, I want to be able to look at these prostate cancer glands and be able to see what's inside the nucleus. How many nucleoli can I see? What resolution is there? Are there pink secretions? Is there blue mucin? So we want to, if I'm going to ask pathologists to move to a digital format, the image should be really good. It should be even better than a glass slide image, or at least equivalent to it. So a number of studies have been done, and this data has been presented to the FDA. And today, up to date, there are 3 scanners which have been approved by the FDA. We also have an AI algorithm for prostate cancer detection, which has been approved by the FDA. So this is the latest scanner, which was approved by the FDA. And we now also have scanners dedicated for cytopathology. So this is a whole slide image scanner, which is developed for cytology. And it has a unique 3D volume scanning technology. So it can acquire multiple Z-stacks and also maintain good scanning speed. It can load up to 400 slides, cytology slides. So if you look at this cluster, we are used to, as pathologists, to focus up and down to see details within these cells. But in a 2-dimensional scanning, that's not possible. So with Z-stacking, you can now see more details in this cellular cluster because it has been scanned at different planes. So this is another cluster where you can see, if I scan just one plane, X and Y, I will only see one cut of this. But if I scan in different planes, you can see and perceive it as a 3D cluster. That's what we are used to do in cytology. There are small scanners now which can sit on your desktop. So look at this scanner compared to a microscope. It's almost like a baby microscope. And you can do a lot of activities with this. You can share images, you can capture images. So this is a remote on-site, a remote consultation for a patient for on-site evaluation. And you can see we use the small, tiny little microscope, but look at the resolution of the cells. You can also export these images, you can share these images. And this is something that we are starting to implement at our hospital. So we can have several hospitals who are connected to our main campus have some of these devices so they can share cases with us. We can do frozens remotely, and we can also acquire images for AI. So this is an example of anatomical pathology lab information system and its integration with a digital workstation. So if I was to just scan slides without a context of the patient, all of the work that I'm showing to you will be of limited value. So multiple areas of pathology labs still have many manual steps and they lack standardization. So in order to prepare the lab to create digital images, we have to focus on all aspects of the workflow. We have to train histotechs, we have to train gross room techs, PAs, pathologists, residents. Everybody has to understand this workflow and the critical role of standardization. So when we are thinking about scanners and which scanner to buy, it depends on your application. Are you part of a university? Are you a reference lab? Are you focused only on clinical work, or you want to do education and research? How many cases will you scan? How many slides do you produce a day? What is your staffing? Do you have histotechs who can be devoted to this? And what is your existing system? What are you trying to displace? What are you trying to replace? So you have to be realistic, and it's not just money that is critical in this. It's also your adoption. It's how realistic are you going to be. You might just start by buying one small scanner and start building applications around it. So people always ask me, what if we are just starting out and we don't have the funding? I would say start small, focus on something which is realistic. So some of these scanners, if you look inside the box, it's a microscope, with objectives, but they've been designed to create opportunities to share these images more easily. So over the last decade, the cost has continued to go down to make a H&E slide digital or a cytology slide digital. And adoption continues to increase. So this is more true than ever during COVID time, where we saw about 30% increase in a pathologist. There were pathologists who never wanted to sign out digitally. They love their microscope. But during COVID, they decided they want to move to digital. So there is going to be a cost, the scanners, the servers, the storage, but you also need to fix the lab. You need to implement barcoding. You need to have tracking in place. So all these are changes that will automatically occur in a lab when they decide to go digital. But going digital is not going 100% digital always. It could be you focus on one area, right? But you still have to have an opportunity to improve all aspects of your workflow: hardware, software, people, procedures, and data. You also have to connect the whole slide images, the images that you acquire, with your lab information system. And you have an ability to bring different types of information into your monitor when you are signing out cases now. So we have to build interfaces between the systems and the electronic medical record. But the goal is ultimately, we should be able to see the images that we want in the context of the patient and apply image analysis and AI tools on it. And so the scanners should be not focused on one scanner or two scanners. There might be a scanner that you buy to do immunofluorescence. There might be a scanner which can do Z stacking. So today, what we've seen in the last 10 years is more interoperability between the types of scanners and the types of systems that you can integrate with. And this really brings us into a world of computational diagnostics. So I'm going to briefly share with you what we've done at our university. So this is the building where my office is. I showed you that large new hospital. It's just around it. So this is the cancer hospital, and our volume continues to go up. So we have approximately 90,000 surgical pathology cases every year, and about 600 to 800,000 slides, which include H&E and special stains, roughly 3,000 to 4,000 slides per day. And so in January of 2017 is when we first started building this operation of digitizing slides. Our first scanners were installed in May of 2017. And then July of 2017, we started to create barcoding and tracking and digitize our slides. We moved to a new lab information system in July of 2019. And then we started working with outside hospitals in November of 2019. And right before COVID, we moved to a remote location, a labs where all these scanners were installed. So this is the cancer hospital, beautiful building. And this is the space that we first moved into. You can see all these scanners, but it was not in the histology lab. And there was a problem because slides had to be brought here. It was a 10-minute walk from the histology lab. So, but we started scanning slides. We started to gain experience with how to scan slides. How do you integrate these with the lab information system? So all the slides were initially not barcoded. So we had to start by applying barcodes on these slides. We had to bring the slides from the archive. So we went back 10 years into our archive and started creating digital images from these slides. So once the slides were digitized, they were available as patient material. And they could also be used for research and education. So this is a remote hospital. It's about 90 minutes away from Columbus. And we started by installing a small scanner there. So pathologists who are there, we usually have one or two pathologists who travel to this hospital. They can connect to a specialist. They can show us very difficult soft tissue case to an expert pathologist. So this was around November of 2019. But we started to train histotechs on how to operate these machines and how do you make a good image from a good H&E slide. So we made a lot of improvements in our histology lab because pathologists were reviewing these images and they were giving instant feedback to the histotechs. So this is the workflow. Slides are prepped and stained in the histology lab. They are digitized, they're assembled into cases, and QA is done on these by the imaging technologist, and they're distributed to pathologists, so to their workstations. All the tumor boards are now digital. All the QA is digital, so I can show a case in real time to a pathologist. So it's really has helped us impact on the workflows, which has resulted in creating opportunities for research and education, in addition to clinical workflow. So this is an example of a office where you have your EMR and your lab information system, the viewing monitor, and you can do different things on the third monitor. In my office, I have 3 monitors. Some of the pathologists have 2 monitors. Some of them only have 1 monitor. This is a home setup where you can see the workflow is being done. This is my work list where I can see the cases for today, and I can click on one case. I can see all the clinical information, and I can see which slides are available for me to review digitally. So we scan all the slides now, and before I get to work, all my slides are available to me. So today I am on clinical sign out. I have 43 cases. The resident has already reviewed those cases ahead of time, and they will just come to my office. We're going to review the cases on the monitor. And I also have a medical student with me today. So both of them can sit with me and review these cases. I can click on the link. I can see the H&E slide. If I order an immunostain, I can see that immunostain, which has been scanned by next day. So scan slides are instantaneously available in the image management system. No waiting on folding or waiting for delivery. And this has been really, really helpful for clinical sign out. So you can measure things, you can annotate things, you can also view them simultaneously. So if I'm doing an immunostain on 2 glands of prostate cancer, I can see them side by side with the stains, immunostains, and the corresponding H&E slide. So if I move up on this image, I will move up on this image as well. So this is an example of education using digital pathology. During COVID, we were doing remote sign out with trainees. So this is a setup of a remote sign out. So the collaborator and the residents are working together and sharing. So you can see 2 or 3 people can be on, maybe even more. And we can start consulting with colleagues. So if I have a challenging case of, I want to show it to a dermatopathologist or a neuropathologist, I can just see if they're online. I can invite them, or I can send them an email link. We've also recently launched a consult service. So this is a web-based platform. So if you have a challenging case in Lahore, Pakistan, and you want to share it for a consult with us, you can create an account in this website, and you can assign the case, you can send it to us, and the pathologist, you can even choose the pathologist who you want to review this case. And this is a consult service that we've started to offer. We get consults now from Japan, from India, and we're working on a collaboration contract with a hospital system in Saudi Arabia and Brazil. But we also get consults from within the state, within Ohio, and even within the United States. So once the slides are uploaded into the consult platform, the consultant can review them. They can add their diagnosis, and so it works out really well. So with the help of the small scanner, which I showed you earlier, we've also started to work on offering a FNA service in a remote hospital. So again, small scanners, which could be on your desktop. They're literally, you can carry them the size of your palm and very light. This is a setup for frozen sections. So you can see residents are working on it. They are preparing the slides, and they're loading it in this machine. And pathologists can review them remotely. Surgeons can review them remotely. So it's really created a lot of educational opportunities for trainees to learn and preview cases during FNAs and frozen sections. When the slide is loaded in this machine, the pathologist gets control of the image of the machine. And routinely, they can do this from a remote location. Our neuropathologists are 15 minutes away, so they routinely use this system to do frozen sections with neurosurgeons. So we have almost 3.3 million slides now, which are now available for education and research, and also a part of our clinical archive. So in general, we have more powerful tools which are available to pathologists: viewing tools, annotation tools, manipulation of the image, snapshots for documentation, for publications, for PowerPoints. And you can start to use AI on these. And many of these tools are open source suite of tools. So for me personally, digital slides have improved my workflow because of the direct interface to the lab information system. Sharing cases with consultants clinicians, colleagues, going to tumor boards, flagging cases for research and education, and even sharing control slides from the histology lab. Um, we we do spend 10 to 15% of your time per case is spent on digitizing it. But once they are digitized, we don't need to move glass slides anymore. We can go directly from the cover slipper to a scanner to the right pathologist. And all the prior cases are instantaneously available. So it's been a good experience so far. But there are still things we cannot do easily. We still have to do polarization. It's not easy to do, but there is a new scanner now which can do polarization, like Congo Red. We have to learn. We had to learn how to teach residents using digital slides, and there are some differences you can see with glass slides versus digital slides. And you have to relearn. You have to train your eyes, but it takes about 20 to 30 cases of digital review where you start becoming comfortable. Z stacking is now possible, but it's very expensive still because you have to scan the slides at multiple planes. And then HemePad, it's still an area that we haven't digitized completely. But over the last 5-6 years, multiple millions of slides have been scanned, now about 3.3 million slides. Our pathologists are using digital slides for sign out. We started going live with primary diagnosis in March 2018, and we are routinely using telepathology and education and research using digital images. So you can see a number of users continues to go up. When we first started, we were few, maybe up to 10 users a day, but now we are at any given time, 40, 50 users are on the system. So one of the concerns the hospital had was when we go live with this system, it's going to crash the network. But it's not been the case. And we routinely use this every day. Multiple teaching sets, tumor boards, resident teaching sets, multiple research collections, and special requests. So all the consults cases are available digitally. So almost 200 primary diagnosis sign-outs a day via digital pathology, nearly 80 consult sign-outs a day, numerous tumor boards and research, and all our faculty use digital slides. So overall, we've seen a decrease the time to diagnosis if you just count the digital sign-out time versus a microscope sign-out time. We are starting to building diagnostic algorithms to support this workflow. And we are now able to consult instantaneously with telepathology to load work balance in real time, consult locally, regionally, and globally. And I think for the pathologist in academic institutes, such as yours in Lahore, we want to be able to see complex cases, interesting cases, consult rapidly with our colleagues. That's something which has happened as a result of digitizing our workflow. So I'm going to switch gears now, and I'm going to talk about AI applications. So once you have digitized your slides, you've created millions of pixels, and I call that the pixel pipeline, which lends itself to computational pathology and AI applications. So some questions to consider, right? Does AI really work? Are we there yet? Does it make pathologists more accurate? Does it make pathologists faster? Does it really save us money? So these are some of the things that we are experimenting with now. But as one of the biggest impact is in areas where you perform a lot of complex tasks, like counting things, like sorting things, classifying things based on morphology, and looking for a small focus of metastatic carcinoma in a lymph node, or looking for signet ring cells in a gastric biopsy. So some of these tasks now only can take under minutes using image analysis and AI. So once the slide is digitized, once you've created the pixel pipeline, it opens new doors in algorithms for example, identifying these things, quantifying them, and synthesizing the information. So if I showed you this image where you can see all these blue dots and red dots and orange dots, and you want to be able to count and tell, so this is key 67. This literally would take a lot of time for a pathologist. And it will not be the same answer for every pathologist. They will give you a range. But with this system, I can press a button and I can tell you exactly how many of these are +3, +2, +1, and within a matter of a minute or less. So this is ER in breast biopsy. And after pressing a button, you can see there are 40,000 nuclei in this image, and negative and positive. So area analyzes only 11 millimeters per square, and it took 98 seconds. You can analyze the same type of slides. This is key 67 in gastric neuroendocrine tumor. 2 millimeters square area has been digitized and analyzed using image analysis, and you can see within 28 seconds you have the answer. And I will probably get the same answer or close to it if I try this 5 times or 10 times. So it's more reproducible, it's more objective. Same thing with HER2/neu. 0.2 millimeter square area is analyzed, less than 1 second, and the score is 3+. So there are many applications of AI in surgical pathology. So let me show you a few things that we are doing at our institute. So things that are automate repetitive tasks, quantifying, looking for lymph node mets, counting mitoses, grading tumor, primary diagnosis, cancer screening. So all these are possible to do now with AI, predicting prognoses, doing virtual staining. So these are some examples of quantitative image analysis and AI that we have validated at our institute in the last 12 months. So finding metastatic cancer in lymph nodes, looking for cancer in prostate biopsies, looking for HER2/neu image analysis, and even cytology, looking at digital image analysis of 67. So let's talk about, we talked about this, right? So this really makes pathology more objective in this quantitation, right? So this is an example of a HER2 So you can see pathologist is choosing this application and apply the algorithm and choose which algorithm to do. So these are apps that you have on your phone. I can choose the app for HER2/neu breast cancer and run it. I can see the number, I can see the score, and I can put the score in my report. So in real time, here you have another example. So I am basically in the same monitor, but now I can start to do more automation, more image analysis using the same algorithm. Each algorithm has to be validated and tested against a glass slide review. But like I said, it really makes it more objective and faster and more standardized. So here is a cytology case where you have biomarker, and you can see I can do ER, breast cancer AI using image analysis. What about finding key 67? This is another application where I can choose the area. I can do Ki67 runs, circle the area, and it gives me an accurate count every time this algorithm is run. So this is the area analyzed, and you can see within minutes, I have the score. What about looking for lymph node mets? So this was a study that was done where diagnostic assessment of algorithms, AI algorithms, were assessed for detecting lymph node mets in women with breast cancer. So the conclusion was, in the setting of some deep learning algorithms achieve better diagnostic performance than a panel of 11 pathologists. So this is again a research study, but it points to the fact that, so this is an example of a workflow where pathologists can have these lymph nodes be screened before they even start looking at the lymph nodes. So if you have 300 lymph nodes in your work today, and you had to look at each one of them, you're talking about at least 300 minutes or maybe 150 minutes. But what if this was done before you even came to work? Think about that possibility, right? So again, you choose the algorithm, you choose the application, and these are all the applications available to the pathologist. So this is the metastasis detection, and it circles the regions which are suspicious or it thinks it's cancer and marks that area for you to review, just like a resident might do or a fellow might do. So these are some examples of lymph nodes. You can see some of these foci are really tiny. They're micromats. And we've seen that the sensitivity and specificity is getting better as we run these algorithms. So this is an example of a lymph node mets with a length of 0.18 millimeters. And the computer program started to detect these metastatic foci. So again, this is not something that pathologists cannot do routinely. But if you have a lot of cases today, it would be good to have somebody screen those for you. And just like you do with pap smears. So these are some other examples of, you can see very tiny little foci of metastatic cancer has been detected in these lymph nodes. What about screening for cancer, right? So I'm a GU pathologist. So we've tested a number of algorithms which allow us to find cancer, detect cancer easily. So these are some foci of cancer, which a pathologist has annotated. So that's the ground truth. But you can see the computer has been able to reproducibly find the same foci. And pathologist 1 versus pathologist 2. So these are some examples of prostate cancer foci. So if you look at the dashboard, the computer has already screened these cases and found this focus, which they want you to look at more carefully. So screening is a very valuable tool. And again, it could be done before you even get to work. And these algorithms have been built based on IHCs, and they've been trained with that. So here is another platform for prostate cancer detection. So there are at least 15 different companies now making algorithms for pathologists, focusing on surgical pathology, cytopathology, hematopathology, and other areas in medicine. So AI can provide the following information for grading and quantitation. And so this is the workflow, right? So this is a biopsy. You get your cases in your work list, and it highlights the cancer cases for you and selects those cases, shows you where the cancer is, and then even assigns it a grade. And you have to basically review this, agree or disagree. So this is a tumor length of 0.6 millimeters. And you can see it's been highlighted by the algorithm. And once you agree with it, then this results will go into your report. So here you can see high-grade cancer, prostate cancer, and you can click on it, and it'll create a heat map for you. Same thing here. So this is perineural invasion, and this is high-grade cancer, and you can see it's highlighting the cancer for you. So this is ductal cancer of the breast, which has been detected by, again, I'm not saying we pathologists cannot do this routinely. We can, but this can actually streamline the work for you and show you the cases. And in this instance, there are examples of invasive cancer which was missed on the microscope. finding calcifications easily, microcalcifications, finding invasive cancer. And the red is an area with the highest probability of cancer. So all these are just examples of tools that are now available to pathologists once they have implemented digital pathology. Do you need to digitize all your slides? No. You can just say, I'm going to buy a small scanner and have it scan all my breast biopsies and run the algorithm on it. Or I can use it to train residents, or I can use it for research. So you can see inside lobular carcinoma versus infiltrating ductal cancer. So blue is the lobular cancer, red is the ductal cancer. So what about searching things, right? So when I was a resident, I used to compare my unknown case with something in a book, in a textbook. Today, you can, once the slides are scanned, you can ask the computer to find related images. So your query image here is a subependymoma, and the best match. So the computer pulled out all the cases of subependymoma from the database. What about cytology, right? So there is a new system, which is the Genius Digital Diagnostic System. It already has a CE mark in Europe for screening cervical cancer. So the platform has a digital imager which acquires images just like I showed you, and has an AI algorithm for image analysis, and it displays these images for you. So here you can see all these images the images have been acquired, and areas of concern have been highlighted for the pathologist. So I can click on this image or this image, and I can go exactly back to the pap smear and see these images. What about mitosis detection, right? So here is an example of a mitosis detection algorithm. So you can see the computer has identified several mitoses they want you to see and review. And then at the end of this analysis, they can provide you with a count of mitoses. So is it better than a pathologist? We don't know. But we are doing validation of this. We're learning more and more about these algorithms. So what about other types of imaging systems, right? Not just whole slide imaging. So now today, we can start thinking about ways where pathology is getting very close to radiology, where we can directly image tissues. So this is an example of an image, a block which has been stained with H&E. And you can see I can start to create very high resolution images directly from the tissue to the histology. If you look at this study, in panel A are unstained prostate biopsy slides, biopsies from different patients. In panel B, these have been stained with H&E. So these are cancer, this is benign, but look at panel C. They are computationally generated H&E. So these are virtual stains. And if you look at panel D, going straight from an unstained slide, you can see the computer has marked areas of cancer. So I think we're making a lot of advances in pathology imaging, and some of these are still research tools, but they're making their way into clinical. Look at this example here. So here you can see cancer slide, a core of prostate biopsy, which has been stained and scanned with an imaging device for 3D non-destructive. So we haven't destroyed the biopsy, but even without doing the stain, you can see the computer has marked areas of cancer versus benign. So you can see more stroma in the benign, less stroma in the cancer, and you can see the cytoskeleton of this whole core. And so these are some new technologies that will come into play very soon. Here you can see virtual staining using AI technology. So on the left-hand side, you have histologically H&E stained kidney tissue sections. So routine H&Es. But on the right-hand side, you have images which are created using computational pathology. So tissue which is stained with computer artificially, but they look very similar to a H&E slide. And if you put them side by side, many pathologists won't be able to tell the difference, that which one is virtual stain or H&E stain in the lab. This is an example of the scanning microscope which scanned this paraffin tissue underwater and then created an H&E image directly from it. So you can see the resolution is continuing to get better. And these systems will eventually, maybe it might take 5-10 years, but they will become part of our diagnostic workflows. Where imagine a patient who has a polyp and it's been scoped, endoscopy has been done, images have been acquired of the polyp. Now you can apply these in vitro and in vivo microscopy technologies to create images like this directly from the polyp within the patient. So pathology is getting very close to radiology, and radiology is getting very close to pathology. Some people think there will be no pathology. It's just all going to be diagnostic medicine. And we will train, just like we do in pathology, to look at images, to look at pattern recognition, which we are very good as pathologists. So putting this all together, it's really exciting time for pathology. We have digital pathology and AI. It's actually no longer 5-10 years away. It's here today. We're starting to use it in the clinical areas, in diagnostics, in research, and education. And the value proposition has really been, if you start to create images from the glass slide, with the glass slide, you can only do so much, right? You've reached the end of the life of that glass slide. You can, after a few years, the slides will start to get old and dusty and the stains will start to fade. The cover slip will start to peel off. But once it's digitized, you can use that image forever. You can use it for image sharing. You can use it for education, research, and applying AI tools on it. We have an opportunity, because we have a shortage of pathologists worldwide. We have an opportunity to bring these images to subspecialists who can review them remotely, offer their opinion. We also have started to build systems where we can display these images, just like radiology, in the clinical systems. And once this data is created, it becomes a very valuable tool for research. All the algorithms that I showed you today, they would not have been possible if we could not test it on glass slide converted images. So it's really a continuous cycle. And now I would say large academic centers in Europe, even in Asia, and the US and Canada have started to create large pools of imaging data. Some of them is more research oriented, some of it is very clinically oriented, but really have an opportunity to bring all the right information and experts together for accurate and timely treatment decisions. So pathologists can now be going to the tumor boards, but they can pull these images on a monitor. They can help to guide the care of the patient. Depending on their expertise, they might be a molecular pathologist or a hematopathologist or a breast pathologist. This is an opportunity to bring the right information to the right pathologist for the right diagnosis and ultimately for the right treatment. So how can AI help me, right? How can it help you? It can assist me, it can augment my diagnosis, or it could be an autonomous self-driving diagnosis. And we've already been doing this in many areas in pathology, like cytology and hematology, but now it's making its way into surgical pathology. And it's a reality now. You can choose how involved you want to be, how much you want to learn from it, because it is already impacting patient care. It is already impacting research. So all these tools are just tools. They are not, I don't call them digital pathology. I just call it pathology. That is what it's going to be in the future. Um, but what we have learned from our journey here at our institute, it has allowed us to improve our pathology practice, has improved our workflows and quality of our diagnosis. It's been a great tool to learn from AI, learn from collaborators, and also teach the next generation of pathologists. Um, so the use of AI in pathology will continue to evolve, and some of the things might that I showed you may not become a clinical reality in many places until 5 to 10 years from now. But it is going to evolve. It will be mainstream pathology, and I expect it within this decade. So with this, I'm going to stop and see if there are any questions. Thank you so much for your attention, and I look forward to uh, being part of the symposium again tonight. Thank you so much.
Hi, Dr. Parvani. This is me, Umar, again. Can you hear me?
Yes,
Okay,
I can
so
do.
thank you so much for the talk, and you have really caught the wind in the net. How we phrase in Urdu that you have put the darya in the kuza, darya ko kuze mein band kar diya. So that was phenomenal. And if I'm not exaggerating, we all feel like chimpanzees who have just learned to sort out the coins by size compared to what you are doing in pathology. So that's phenomenal. So the plan was that we will have your talk, and then we will have a question and answer session at the end of the all the talks. But if just for your ease, we can do the question answer with you right now, and then we will proceed with the next lecture. Is that
That would,
okay with you, so that you
that
don't
would be
have to
great.
come back?
That
Yeah.
would be great
So
because
so
I have to teach the residents in half an hour. So
yeah, so it's perfect, perfect. So I have a question slash it's kind of a long question, but it have parts. So as you may have known before as well. So we have a very busy service here, and like we sign out more than 90,000 cases per year with only 8 pathologists at hand. So we are really swamped. So we have been discussing back and forth to go to some extent to digital pathology or digitalization. So I know you have partly answered the question in your talk as well, but where to start? What would be the first step to start? So we have the main 3 4 applications we see in artificial intelligence. It's digital pathology, telepathology, research, education. So that's the 4 main pillars which I could gather based on my brief learning. So from where we should start? What would be the starting point?
So I would say, because you have a busy practice, one of the things you
Mhm,
could do is create telepathology opportunity. So some of the small scanners that I showed you, you can
mhm,
acquire one of those scanners for $10,000, $15,000, and you can implement it, the software, and you can start creating opportunity to share cases with each other. And again,
mhm.
it's not going to be scanning all slides, but you can start creating your interesting case archive, and you can start
Okay.
even consulting each other, even consulting
Mhm.
pathologists in Pakistan and even outside. Like I would be
Sure.
willing to look at cases from your institute, just as
Mhm.
a collaboration,
Sure.
connect you with experts in soft tissue or
Mhm.
breast. The second easy application is you can even use free software. Like some of the examples I showed you of image analysis, it's
Mhm.
freeware. You can download it on your app, on your on your computer, and start using KI67. So once you don't even need a whole slide imaging system. As long as you have a camera on your microscope, You can create a JPEG or a TIFF image. You can start analyzing it. You can do studies of this. I know that in Karachi, there is at Aga Khan, they're doing studies just on software which is easily downloadable. So you got to start somewhere.
Sure.
You don't need to buy like some of these big scanners that I showed you. They are like $200,000. So you don't, if you don't have the budget, you don't have the capacity to do it, I would not be discouraged by it. And you can start applying for grants and funding. Even WHO and places like that will offer funding to residents and medical students. And you can start sending them to conferences. I was in the Digital Pathology Association meeting yesterday in Orlando, and last year we had a Pakistani physician who was given full funding scholarship to attend the conference and presented some of the research. This year, there was another colleague from Pakistan, from Lahore, um, who was given the travel award. So they gave them $5,000 to travel to America, be part of the conference. So I think there are many ways you can get involved.
Yeah.
But you don't need to wait for big. You can even collaborate with an academic institute who already has a scanner. You want to do a project, you de-identify your slides, do a research study with them. So you gain familiarity with the technology. So I'm all for staying up with the technology. Like I trained myself. I was interested in it. I always wanted to learn. I did my high school in Pakistan, um, and then came to America for college. But I still think this is something we can do even in a resource limited setting.
Thank you. Thank you. So the second part is, how, okay, so we are busy and we have very limited staffing. So how much knowledge does a pathologist have to indulge the group into this? So we will of course have the companies who will giving us software, or if we end up buying something, and they will have a support staff to assist us. But do we have to have a person in place with us to work the technical details, as well as how much a pathologist should learn about these computational things and algorithms, and to familiarize the person himself?
Well, there are two things to it, right? One is that you are interested in it as a field. So you need to do additional training. Like I'm taking classes now in the computer science area. I'm learning about AI and deep learning, and have taken certificate program. But as a pathologist, as an end user, you don't need to know how to code or be a computer programmer. You just need to understand what the tool will do for you. What are you feeding into it? What is the results? So you can see it. It should not be a black box to you. In terms of pathologist, I would say you should train your histotechnologist to scan the slide, because they already are in the lab. So this could be so we train our histotechnologists. There is a online certificate program for histotechnologists. It costs $400. It's offered by the National Society of Histotechnology, and anybody can take that certificate program. And it's 100 hours of training. You at the end you will get a certificate, and I would recommend training one of your histotechnologists and get them to get trained in it. I will offer a scholarship to somebody who wants to do it. I will pay for their certificate program.
Thank you so much. That's very generous and truly obliged. So we will wait for a few minutes if one of the audience have any questions, and then otherwise we will complete the session.
Thank you so much. Thank you. So tomorrow is the workshop, right? Tomorrow is the
yes.
So
Yes.
tonight.
So tomorrow will be the actual core symposium will start. So this is a pre-symposium workshop. Yeah. So for now, it seems like everybody is still looking and maybe buying digital pathology equipment out there. So thank you so much, truly obliged, and it was extreme pleasure of us, and we thank you for your time.
All right, sounds good. Take care.
Okay. Have a good day, sir. Take care. Bye. So with that, we will proceed to good afternoon, everybody. So we are heading towards the final and fourth lecture of our symposium, a pre-symposium workshop. So our next esteemed speaker will be Dr. Michael Clay. He is he's an associate professor in the University of excuse me, University of Colorado, and he's a molecular pathologist with special interest in solid pediatric tumors. Michael is currently also a director of soft tissue bone and soft tissue pathology in University of Colorado. Um, uh, my exposure to Michael was when he was a fellow. He was my co-fellow in Emory University. He was actually the last fellow of Dr. Sharon Weiss doing the soft tissue pathology fellowship. During the 1 year course when we were together as co-fellows, Michael has told us a lot of things in pathology. He is such an enthusiast and such a knack for teaching. He has a massive slide collection. He used to take training classes, decahead microscopy lessons for all the co-fellows and residents. So he has been phenomenal during his fellowship years as well, and now he is progressing and has published quite a lot in molecular pathology and solid pediatric tumors. So he will be discussing WHO updates from 2020 in bone and soft tissue pathology. So we will start the lecture now.
Greetings. My name is Michael Clay, and today I'm going to be talking about the updates from the 2020 WHO 5th edition of the Bone and Soft Tissue Tumor Classification Guidelines. I'm going to be discussing new entities and molecular correlates. I thank you for your attention, and I thank you for the invitation to speak to you today. During the course of this presentation, I'm hoping to cover a number of topics. In general, I would like the audience to understand the pertinent updates to the new 5th edition of the BST WHO, to differentiate new entities from molecular and histologic mimics, to better understand the landscape of molecular alterations in bone and soft tissue tumors, to know when ancillary testing may be informative and when it provides little utility, and develop a greater appreciation for the complexity of our diagnostic pathology. Overall, this is how the lecture is going to go. I'm going to give you updates on soft tissue tumors and then bone tumors, some updates on nomenclature, grading, and risk stratification, and then an overview of relevant molecular advancements. I will say that there has been approximately 7 years between the 4th and 5th editions of the WHO BST fascicle, and there are a lot of significant updates. For those looking for more information, this article, published by Kalin and Hornick, is an excellent overview of these updates, as are the textbook written by Dr. Hornick and the WHO fascicle itself. All right, let's start with new entities. I'm going to break these into different categories. So for the adipocytic tumors, new entities we're going to be discussing are atypical spindle cell / pleomorphic lipomatous tumor and myxoid pleomorphic liposarcoma. For vascular lesions, we're going to talk about epithelioid hemangioendothelioma with YAP1 TFE3 gene fusions. For the smooth muscle tumors, we're going to be tackling the complex topic of inflammatory leiomyosarcoma. In the fibroblastic myofibroblastic camp, we're going to be discussing angiofibroma of soft tissue, EWSR1 SMAD3 positive fibroblastic tumor, and superficial CD34 positive fibroblastic tumor. And then the tumors of uncertain differentiation, we're going to handle the N-track rearranged spindle cell family of tumors. And then finally, the round cell tumors. We're going to be discussing the CIC and B-core rearranged sarcomas, as well as the EWSR1 fused sarcomas that have non-traditional fusion partners. Throughout the course of this lecture, I'm going to be highlighting what I think are the most important relevant takeaways in these little orange boxes. So keep an eye out for those because I think they're the highest yield content in the talk. All right, soft tissue tumors. Atypical spindle cell / pleomorphic lipomatous tumor, which is a mouthful and sounds like many of the other entities we already have in BST. This is a benign adipocytic tumor, and it's distinct from atypical lipomatous tumor and spindle cell pleomorphic lipoma. Most of these occur in the limb and extremities, with a predilection for the hands and feet. That's pretty unusual for the other entities in the differential diagnosis. They're very rare in the head and neck, trunk, or retroperitoneum. They are infiltrative. They lack MDM2 gene amplification. They exist on a morphologic spectrum. You can think of these as sort of on a spectrum between spindle cell lipoma and fibrosarcoma-like lipomatous neoplasm. They do have loss of RB1 expression with RB1 gene deletion. They typically have a benign clinical course, however, 10% will recur. So the main contenders in the differential diagnosis here are obviously going to be atypical lipomatous tumor and spindle cell or pleomorphic lipoma. ALTs and well-diff liposarcomas consistently show amplification of the MDM2 gene, and so that is not seen in this entity. They're usually in the deep soft tissues or in the retroperitoneum, not in the extremities of the hands. Spindle cell pleomorphic lipoma, although they also have loss of RB1, these are usually in the head and neck of adult males. They're also not infiltrative, and that's an important distinction. They typically show diffuse CD34 positivity, which may be helpful. This is what atypical spindle cell / pleomorphic lipomatous tumors look like. You can see they have many of the features we would attribute to the entities in the differential diagnosis. So they have this myxoid matrix. They have neoplastic adipose tissue, variable sized lipoblastic cells, and they have sort of a smudgy atypia like you would see in a pleomorphic lipoma. To recap, this entity, atypical spindle cell / pleomorphic lipomatous tumor, is usually seen in the extremities, and they exist on a morphologic spectrum. I think of them as sort of pleomorphic spindle cell lipoma of the hand that's a little bit too infiltrative, that shows some unusual features. So far, they have a benign clinical course. Myxoid pleomorphic liposarcoma. This is an exceptionally rare tumor in children and young adults and has a predilection for the mediastinum, which is a very unusual location. There seems to be some association with Li-Fraumeni syndrome or TP53 abnormalities. These are a mixture of classic low-grade myxoid liposarcoma and pleomorphic liposarcoma histologically. So far, there's been no recurrent genetic abnormalities identified in these tumors, and they are clinically aggressive with a high rate of local recurrence and metastasis. Let's see what they look like. So you can see here, we have many of the features of myxoid liposarcoma, but sort of admixed with the features of pleomorphic liposarcoma. Here's some examples of those classic entities. And you can see we have the chicken-wire vasculature of low-grade myxoid liposarcoma, as well as these unusual large pleomorphic cells like one would find in pleomorphic liposarcoma. You can see that there are lipoblasts within this lesion, clearly identifying it as a lipogenic tumor. Remember, these occur in children and young adults, which is not where you see pleomorphic liposarcomas. And they have true atypia, which is not what you see in myxoid liposarcoma. There's no recurrent genetic abnormalities that we've seen of yet, although, they look like they should have something. And so I imagine as we get more cases, we'll probably find something recurrent. And these are very aggressive. So you could think of them clinically like a pleomorphic liposarcoma as far as their aggressive growth. Angiofibroma of soft tissue is a benign fibroblastic lesion that's mostly seen in the distal extremities. They have a prominent, delicate capillary vascular network, much like myxoid liposarcoma, with admixed thicker-walled blood vessels, much like we see in solitary fibrous tumor. A lot of these tumors you'll see are sort of morphologic mix-ups of things that we have seen in the past. There is rare degenerative type atypia, and these ones do have a recurrent gene fusion between AHRR and NCOA2. This is the first paper that described this entity, excuse me, and you'll notice it was published in 2012. And so this one took a really long time to make its way into the new edition of the fascicle. Many of you will probably recognize the NCOA2 gene as part of fusions we already know in other tumor entities. So I thought I would give you one quick review of things that have NCOA2 gene fusions, just so we can add angiofibroma into this conceptualization. All right, this is a domain view of the NCOA2 gene. All these little breaks are different exons, and some of them are color-coded. And the important thing to know is that the color-coded parts are the activation domains of the gene. And so when you're having a gene fusion, you like to grab the activation domains because they do something. And so most gene fusion breaks will be in the region of relevant domains so that the fusion event can grab sort of the driving force of the gene. There are many different tumors and many different breakpoints for this gene that we already know about. And so non-canonical alveolar rhabdomyosarcomas can have PAC3 NCOA2 fusions. Acute myeloid leukemias are probably the best known, especially the ETV6 NCOA2 gene fusion. And then mesenchymal chondrosarcoma, which is another great classic bone and soft tissue entity, has the canonical NCOA2 gene fusion. And then we can add to that these two different breakpoints for angiofibroma of soft tissue. This is classically what the textbook will tell us these tumors look like. You can see this very delicate arborizing capillary vasculature, chicken wire pattern, much like you see in myxoid liposarcoma. However, we don't have any lipoblasts. And although these are the textbook examples, a couple of recent cases that I have seen looked more like this. I think this is more sort of prototypical, with these admixed, very large ectatic vascular channels that mimic what we typically see in solitary fibrous tumor. So remember, this new entity is in the extremity of adults. Morphologic combination is sort of like myxoid liposarcoma and solitary fibrous tumor. So if you find yourself with either of those two differential diagnoses in the arm of an adult male, think about this tumor. Luckily, we can do NCOA2 gene fusion analysis pretty easily because it's so ubiquitous in other tumor types like leukemias, and these typically have a benign clinical course. Inflammatory leiomyosarcoma. This is the first time this entity has been broken off as a separate unit. It was formerly just a morphologic variant of leiomyosarcoma. It's usually in the extremities, but there's nothing really specific about the location or clinical presentation. They're very unusual molecularly in that they have a distinctive near haploid genotype that usually results with subsequent chromosomal doubling, giving you loss of heterozygosity. They are notable for the presence of significant inflammation that is often obscuring. However, this is a very controversial entity, and I'm going to tell you why relatively briefly. This paper was published in 2020, so very recently, about inflammatory leiomyosarcomas and histiocyte-rich rhabdomyoblastic tumors. The paper goes on to essentially state that this tumor type has been described multiple times. It definitely has rhabdomyoblastic expression, and so they advocated for the diagnosis of inflammatory rhabdomyoblastic tumor for what we've historically called these inflammatory leiomyosarcomas. Their cases all occurred in the extremity of young men, typically in the extremities, and had indolent behavior. Again, they had this similar near haploid genotype. Striking inflammation, but they did have rhabdomyoblastic staining with expression of MyoD1 and myogenin. This is what these tumors look like. You can see there is abundant obscuring inflammation, and you would be hard-pressed in some of these photos to highlight the neoplastic cells from the background. Maybe the right one's a little easier with these plump cells. But when you throw stains on them, here's a desmin, extensive staining in the background, And even more striking is the MyoD1 stain. There are a lot of tumor cells here that are expressing rhabdomyoblastic antibodies. As if that wasn't complicated enough, there are more influential bone and soft tissue pathologists taking a bite of this particular topic. This particular paper, called Inflammatory Leiomyosarcoma, shows frequent co-expression of smooth muscle and primitive myogenic phenotype. And they wanted to call the tumors low-grade inflammatory myogenic tumors. So, whether we call these things sort of a new variant of inflammatory leiomyosarcoma or these other two proposed entities, it's important to know that they have this rhabdomyoblastic phenotype and they have an indolent behavior. That's pretty unusual. If you saw something this chaotic with myogenin staining, you'd probably think of some sort of rhabdomyosarcoma and therefore some sort of malignant diagnosis that needs chemotherapy. Whereas this entity, despite its striking rhabdomyoblastic phenotype, has a relatively indolent behavior. So I expect there's going to be a terminology change in the future as the important movers and shakers in the field decide what to go with as far as terminology. But I think sort of rhabdomyoblastic ought to be part of the terminology, given the unusual phenotype and the risk for differential diagnostic errors. EWSR1 SMAD3 fibroblastic tumor. This is a provisional entity and is considered a benign fibroblastic lesion, which is very striking because EWSR1 has traditionally sort of correlated with more malignant diagnoses. Not always, but often. These have a female predilection, again, usually in the hands and the feet. They have nodular growth in the subcutaneous tissues of the deep dermis. They sort of have a DFSP-like growth pattern with intersecting fascicles of spindled cells, but they do display a zonation with central hyalinization or infarction that's pretty striking. They have a very unusual immunophenotype. So they have diffuse ERG expression with no SMA or CD34 staining. So ERG is typically a really great vascular marker. It's also present in epithelioid sarcomas and prostate cancers that have ERG gene fusions. We typically use it as a vascular marker. Here's the first paper that described this entity. And this is what it looked like. It sort of looks like a DFSP infiltrating through background adipose tissue, very bland spindled cells. I think it's good at this point to discuss the EWSR1 spectrum a little bit because it's grown so much over the past several years. And so in 2010, if we talked about which tumors had EWSR1 gene fusions, it would look something like this. And these would be all of our classic entities: Ewing sarcoma, clear cell sarcoma, angiomatoid fibrocysticystoma, etc. Both benign and malignant tumors are represented on this list. Angiomatoid fibrocysticystoma most notably as our benign tumor. This is what the EWSR1 spectrum looks like now. That is a shocking number of partners and a shocking number of disparate tumor types. And you can see that we now have SMAD3 tucked in here on the side with regards to this entity. This particular paper by the McCalls is an exceptionally good paper with regards to histology for this tumor type. It's very rare, and they have a great collection of what the tumors might look like. You could see here this really nice central hyalinization that when you get the entire tumor is sort of striking. You might think this looks like DFSP or maybe solitary fibrous tumor, but this central hyalinization is pretty unusual and would give you pause. And if you're lucky, you get an ERG stain and you get saved from making a diagnostic error by the completely unexpected diffuse ERG expression. Here are some more photos from that paper, which are exceptionally good. Actually, sorry, this is from a Hornick paper that also is showing this hyalinized sort of central aspect. So think about these when you have this unusual zonation and this sort of morphologic overlap of DFSP and SFT. Diffusely positive for ERG, and it has EWSR1 gene fusions. So beware of misclassifying this as clear cell sarcoma. Although this doesn't look at all like clear cell sarcoma, it occurs in the same location in the extremities, and it also has an EWSR1 gene fusion. And so if all you knew was this had a gene fusion and didn't know the partner, you might get those things confused. Superficial CD34 positive fibroblastic tumor is a low-grade lesion of the skin and subcutis that has a very unusual pleomorphic pattern. It contains highly cellular fascicles of very glassy cells. This is what they look like. And so these tumor cells are very, glassy with this hyper-eosinophilic but very smooth cytoplasmic features. They show diffuse positivity for CD34, which is part of the namesake, and they're also keratin positive in most examples. They have a great prognosis. The histology can be quite variable in practice, though. Here's a case that I had. You can see that there is still sort of smudgy atypia and very exceptional eosinophilia, but in this case is a little more spindled, and you lose some of that, overtly glassy look. They have atypia in excess of their mitotic activity. So these are pretty ugly cells, but you'll really be hard-pressed to find mitoses, and that's pretty helpful. It's one of the tumors that is sort of a discordance between atypia and mitotic activity. Again, these have a very good prognosis, and so you wouldn't want the atypia to mislead you into calling this a malignant process like a spindle cell carcinoma, perhaps. All right, the NTRK rearranged family is been put into a provisional category, and it's very critical given the clinical implications. NTRK gene rearrangements are now identified in a wide variety of entities. And so, although we all know secretory carcinoma of the breast, infantile fibrosarcoma, congenital mesoblastic nephroma are big NTRK molecular families, there really is overlap in pretty much every specialty any of us might be practicing. All the way down to the generic sarcomas, which sometimes might have NTRK gene fusions. The treatment responses to NTRK targeted therapy are striking. This is a fantastic paper by the group out of St. Jude Children's Research Hospital. And this little child had an infantile fibrosarcoma on their arm, massive tumor. You can look at the imaging studies here. This is a very large and very terrifying tumor. The fusion was identified and they started targeted therapy. After 2 cycles, the tumor looked like that. And after 4 cycles, it was essentially gone. We have also seen treatment response in aggressive adult disease. This is a paper detailing a 47-year-old woman who presented to an outside hospital with abdominal pain and had a large rectal mass, which then was shown to have multiple metastatic deposits throughout her abdomen. This is what happened with her therapy, and you can see the PET images. Essentially, the tumor melted away. This is why the NTRK inhibitor therapy was considered the first cancer agnostic treatment, because it didn't really matter what tumor type it was. It mattered what gene fusion was present. Larotrectinib was the first FDA-approved drug, and it is the first FDA-approved tumor-agnostic therapy we've ever had come out of the FDA. Histologically, NTRK-rearranged tumors are hard to identify, but they often have an unusual phenotype in that they co-express CD34 and S100. Fortunately, we don't only have to rely on morphology and those stains. There is now a pan-TRK IHC stain that is exceptionally effective at picking up all of these different gene fusion partners. And so it's a very good screening tool for many different entities in many different scenarios. It's also relatively easy to validate and looks relatively clean, and so it's a nice antibody, which is lucky for the scenario. This is an example of what it looks like. Here's a secretory carcinoma of the breast, and you can see this very clean, distinctive pattern of staining. It's incredibly sensitive, but it's also incredibly specific. Here's some more photos of some random tumors within this family. And again, more positivity. I think of the antibody sort of like our ALK stains for IMT. It doesn't always show exactly the same pattern, but it's reliably positive in the tumor. You can screen these things with CD34 and S100, but just know that the clinical implications here are massive. Limb salvage therapy versus a pill. Okay, let's switch to bone tumors. Let me check my timer real quick. There we go. Okay. All right. The Ewing-like round cell sarcomas of bone and soft tissue. This is a growing family. Initially we had Ewing sarcoma and things that looked like Ewing's, but we couldn't tell what they were or didn't have the fusion. They were called Ewing-like. Now we know that there are multiple distinct entities in this family, including the B-core and CIC rearranged sarcomas, which are the biggest parts, as well as some EWSR1 gene-fused tumors that are to non-classic partners. In general, these are rare, and you're going to need some sort of special ancillary testing to diagnose them. But here's a brief conceptualization that will help you make the morphologic diagnosis. If we think about Ewing sarcoma on a spectrum of atypia, right? Ewing sarcoma is very monotonous. It has exceptionally round, uniform cells that are easily recognized. We have classic stains like NKX 2.2 and CD99. We know the gene fusion partners, although rarely we can have FUS instead of EWSR1, so be aware of that. If we look at a Ewing sarcoma that looks slightly more bland, and I'll show you examples of this, we end up with something that's now being called B-core sarcoma because of identified fusions. These have B-core, CCNB3, or perhaps mammal-3 gene fusions. Importantly, these occur in the long bones. These are a bony tumor of adolescence. They are less atypical and less aggressive than Ewing sarcoma. There's a very good B-core stain that people can do to help identify these. On the opposite end of the spectrum, if you have a Ewing sarcoma that just looks really atypical, many of these, quote, atypical Ewing sarcomas are now known to be CIC sarcomas. This is the largest grouping of these sort of non-Ewing's fused things that were in the old family. They most often occur in young adults, and they are extraskeletal. They typically have CIC DUX4 gene fusions, but be aware the fusion can be cryptic, and so FISH may not identify it in up to 15% of cases. These are aggressive tumors, more aggressive than Ewing sarcoma and more atypical than Ewing sarcoma. All right, knowing this, let's do a quick quiz of those three entities. Let's look at number one. I see sheets of exceptionally monotonous cells, some red cells here and there. Chromatin is all very clean, finely dusty. Not much to say about it. It's very monotonous. How about number two? All right, well, it's a little bit different. There's maybe a little bit of spindling to the cells. There's some sort of maybe matrix happening that's disrupting the pattern. It looks a little bit more bland than the last case. We have these large ectatic vessels, but just a different morphologic look, I think, than the last one. And then finally, we've got this, which is, again, very monotonous. However, it looks more atypical. We can see karyorectic debris and sort of nuclear fragmentation of cells. The cells have a bit more cell-to-cell variability. There's a bit more hyperchromasia, more ugly nucleoli. Okay, so we're going to put these on the spectrum. This one was obviously going to be the Ewing sarcoma. That would be B-core, and this would be the CIC. Again, sort of, you can look at the atypia spectrum. This looks quite a bit worse than that, and this looks sort of more cellular, more packed in than the B-core sarcoma. This spindling and sort of some subtle myxoid change is a nice indicator for B-core. Remember, the CIC sarcomas are in soft tissue, the B-core ones are in bone. You can do ancillary studies to help identify many of these. Okay, what about the EWSR1 non-ETS family? What are the ETS family? Well, if you think about Ewing sarcoma and all the different gene partners that can have, that's essentially the ETS family. So ERG, FLY1, and ETV, FEV1. Most of these non-ETS family tumors are case report-driven entities. They include EWSR1 PATS1 and EWSR1 NFAT-C2, and those are the two that I'll discuss very briefly. The EWSR1 PATS1 tumors occur in deep soft tissue, and I sort of think of them as a mimic to a myoepithelial tumor because they have S100 and SOX10 positivity. They can have desmin. They can also have MyoD1, which is going to be very confusing should that happen to you. These NFAT-C2 ones occur in the long bones, and they have very sort of epithelioid nests and hyalinized stroma. These are not tumor entities that you're going to do any patient harm if you miss them. Call these, sort of odd Ewing sarcomas. But it's important to know that they exist because, as we get more cases of them, I'm sure the therapies and the sort of risk features of them will be better elucidated. Okay, let's talk a little bit about nomenclature, grading, and risk stratification. Terminology updates are an important aspect of the WHO, and you should know that melanotic schwannoma is no longer an accepted term. We now regard those tumors as malignant melanotic nerve sheath tumor. You recall these often arise from the spinal nerves in adults, and they are associated with Carney complex. They express S100 protein, SOX10, HMB45, and melon A. But they've shown to have an aggressive behavior with recurrence and metastasis. And so this sort of schwannoma benign diagnosis is no longer appropriate. Dedifferentiated liposarcoma should now follow the French grading rules, and myogenic differentiation should be noted as both have an impact on survival. You can see this survival curve based on French grade. which is now something we need to do. And here's sort of the French criteria. Solitary fibrous tumor needs to be risk stratified into groups. This paper by D'Amico et al. In 2017 shows the 4 variables that we use to risk stratify these tumors, being age, tumor size, mitotic rate, and necrosis, which will put us into low, intermediate, and high risk. Sometimes we do have frankly malignant SFTs, and those are ones that have already metastasized or proven that they're clinically malignant. Otherwise, we should be risk stratifying the tumors. The takeaway is that if you're a young person and you have a tiny tumor, they're not really going to do anything. All right, a little bit of updates on molecular testing. Here's just some of the updates to the molecular alterations in soft tissue tumors. Some of these are exceptionally rare. Some of them you definitely can't test for. There's a lot. And so I'm going to identify and highlight 5 that I think are particularly useful and can actually affect sort of clinical practice now. Solitary fibrous tumor is a big one. They have NAB2 STAT6 gene fusions, and we now have STAT6 immunohistochemistry, which is widely available and exceptionally useful. Epithelioid hemangioma now has been identified to have FOS and FOSB gene fusions, and there's a FOSB IHC stain that's positive even when the gene fusion is not detectable, so that can be very helpful. EHE, epithelioid hemangioendothelioma, although traditionally has a WWTR1 CAMTA gene fusion, has now been identified as a subset that have YAP1 TFE3 fusions. And unlike conventional EHE, which is sort of small blister cells and very poorly vasoformative, these ones that have YAP TFE3 can have nested sort of poorly formed vessels, which is very different. Luckily, there's a TFE3 IHC stain that we use for other entities like alveolar soft part sarcoma, which is positive in this tumor. And finally, pseudomyogenic hemangioendothelioma, which is another very unusual vascular tumor, contains cytokeratin ERG positivity as we know, but also is now known to be FOSB positive with recurrent fusions with the FOSB gene. Again, this can be stained for, and here's the sort of overwhelming keratin expression that should help you make the diagnosis. I think it's helpful at this point. I'm going to go over these epithelioid vascular lesions a little bit more detail because I think they're confusing and there's a lot of clinical overlap. So if we take these 3 entities, epithelioid hemangioma, EHE or epithelioid hemangioendothelioma, and pseudomyogenic hemangioendothelioma. These are terrible terms, and I apologize. I didn't come up with any of them. There's a lot of overlap in these entities, but they're very distinct when you get down to it. So I'm going to try to highlight differences in histology, molecular findings, IHC, and the clinical variables. So if we start with molecular, like I'd mentioned, epithelioid hemangioma is now known to have FOSB gene fusions, just like pseudomyogenic hemangioendothelioma, but they have different partners. EHE has a completely different subset of gene fusion partners. Because of the fusions, these 2 entities will show expression of FOSB. This will not. And in the subset, we'll be able to get TFE3 staining out of the EHEs. If we look at the morphology, epithelioid hemangioma is clearly vasoformative. It's like an epithelioid vascular tumor, whereas pseudomyogenic is a very spindled tumor with very little to no vasoformative growth. And then EHE sort of depends on which of these gene fusions. Either we get sort of the classic blister cells of EHE, or this more sort of clustered rare vascular pattern of this new variant. Both EHE and EH can have corded growth, though, and both of these bottom 2 can be very poorly vasoformative. They all can have cytokeratin. Pseudomyogenic is going to have a lot more than the other ones. EHE usually has some pretty good keratin, and EH typically doesn't, but can. All 3 will have ERG positivity. Very different clinical behavior. EH is the most banal. They do recur, and if they're in a bone, they can be very locally aggressive, but they don't typically metastasize or do any sort of classic malignant behavior, just locally bad and recurrent. EHE exists on a whole spectrum. They can be very banal, or they can be exceptionally clinically aggressive. And pseudomyogenic It's often present as multiple nodules and often recurs, and still sort of being elucidated how bad it is. All right, moving on to our last molecular update on malignant peripheral nerve sheath tumor. And this is on the loss of a nuclear stain, which is a trimethylation stain, H3K27Me3 or trimethylated stain. This is a loss of stain. And so most normal tumors and tissues will express this antibody, and we see an absence of positivity in MPNST. The worse the MPNST, the higher the grade, the more likely this will be lost. It's not seen in benign nerve sheath tumors. It's not seen in synovial sarcoma or SFT. And so although it's not lost in every MPNST, it's retained in pretty much all of the things in the differential diagnosis, which can be very helpful. So in summary, there's a lot of new entities that we discussed, as well as some entities that are being formally sort of reshuffled, like inflammatory leiomyosarcoma becoming a new distinct entity. And there are new variants of old entities like the YAP-fused E8E that we learned about. There's been terminology and risk stratification updates that can impact decision-making practices, like those in malignant melanotic nerve sheath tumor, D. diff liposarcoma, or SFT using the new risk stratification guidelines. Molecular testing is becoming not only critical, but definitional in some instances. And I would say it's approaching the standard of care in these entities here. Certainly with some of these gene fusion sarcomas, you need the fusion to be definitive in some cases. And most of our clinical trials are requiring us to document molecular status. Dedifferentiated liposarcoma is pretty easy to diagnose in the right context, but they still want to know the MDM2 status for trial enrollment purposes in the United States. And so something we're going to need to keep an eye on. I guess my final thoughts on the diagnosis of bone and soft tissue pathology and the updates that we've seen here, I think the field is becoming much more complicated than it ever was, and there's a lot more ancillary testing that we're sort of forced to do. There's more antibodies, there's more molecular correlates. As a bone and soft tissue pathologist, I have a very low threshold to show cases around, to talk to colleagues, to look at the literature. I think this is going to become more common as we move forward, and entities become more rare, more elusive. Only one institution might do a stain or a study that can help you make the diagnosis. And so I think as we move forward in the field, it's going to become much, much more collaborative. Yeah. I thank you for your attention, and I hope you enjoyed the talk. I hope you have a nice day and enjoy the rest of your conference.
So good afternoon, everyone. So we are done with our lectures. So 5 o'clock was the agreed upon time that the speakers will come online for the question and answer session. I have requested them that if they can come a bit early. So I have given them the time of 4:45 p.m. So I'm waiting for their response. But for now, we will the plan is that we will have the question and answer session to conclude today's workshop at 5 p.m. So please stay tuned, and now the banner will be on the screen, but if we will be able to get the speakers to come online for question and answer session, we will start the Q&A session 15 minutes earlier. Otherwise, it will start at 5 p.m. sharp. Till that, take care. See you soon again. Bye. Good afternoon, everyone. Welcome back.
Hi, Dr. Sheikh. How are you?
Good. Dr. Montgomery, how are you? Welcome. I'm so excited to see you after so long.
Yeah, you look the same. I got older. That's
Okay,
not
thank you
fair.
for
What's wrong?
Yeah, no, I mean, you are just too modest, I would say. So how you look so young. Hey, Michael,
Hey, how are you
welcome.
doing?
Good, good. How are you?
I'm
Thank you
doing
so
very
much for
well.
the time and waking you up so early. I hope
Yeah, no
that's
problem.
okay.
It's not so early now.
Yeah, for Dr. Montgomery, yeah, I think it worked out perfectly. So, so here we are. So, should I shoot the questions?
Please.
Okay, so Dr. Montgomery, I will ask you questions first, and then we will turn to Michael. So my first question from the audience is, is it important to mention while signing out the biopsy that we have complete intestinal metaplasia versus incomplete intestinal metaplasia?
So I assume you're talking about stomach biopsies.
That
As
is
of
correct.
this very minute, it probably isn't essential. And the trouble, as I'm sure you know, is that epidemiologically, the incomplete type is more likely to progress to dysplasia and cancer than the complete type. But in an individual patient, it's not exactly so predictive. But epidemiologic data do support that. It's so easy to do, though, that I've started to just do it. Especially because often it's in the setting of mapping biopsies in high-risk patients. And I'm going to guess that you have some high-risk patients in your stable in your practice. So it's not a terrible thing to do. The U.S. American College of Gastroenterology is about to come out with guidelines, and they will suggest that we subtype it. But if there's just one little tiny pocket in a pretty healthy patient, it probably doesn't matter. So I guess you'll have to talk to the colleagues in your institution and figure out what makes sense for them.
Okay, thank you. So the practice model we have here, so I'm working in the largest cancer center in the country. So we get collection centers all over the country, we get the biopsies. So we don't have a much liaison directly with the clinicians. So all
Got
we
it.
get are blind biopsies. So my question regarding this is, so is it okay, is it justified to overuse or be liberal with the indefinite for dysplasia so that they will keep the patient on surveillance? Because we get two types of biopsies. Either we get all the way cancers, people get biopsies when they are there is not a very strong surveillance program in the country. So either we get full-blown cancers, we don't, the things you were mentioning, the subtle changes, we have
Yeah.
passed through that. So we are seeing full-blown T3 cancers all the time. So we don't struggle to that. But if we get a healthy appearing biopsy or Barrett's esophagus or GI or esophageal biopsy, upper GI, so is it okay to be liberal with the term indefinite for dysplasia?
Sounds like it makes perfect sense in your practice.
Okay, so I mean, getting a frequent, so let how we talk about high grade pain in prostate. So high grade pain biopsies will have the same incidence of tumors versus normal benign biopsies, right? So is it the same with indefinite for dysplasia?
Not exactly, because most of the time things that we think are indefinite for dysplasia are really fine, and you can push them one way or the other. But if you call it indefinite for dysplasia because you want to make sure they follow the patient, their protocol is to increase acid suppression and, make conservative measures and then go back. So you may be doing the patients a service. So I see no moral downside to your pushing your threshold for making sure the patients receive follow-up.
Okay, thank you. The next question is, what kind of adenomas among gastric adenomas you see progressing to invasive cancers more often?
So it depends on how you use the term adenoma, but if you use it to indicate a true sporadic lesion in normal flat mucosa, those don't progress very much unless the patient has familial adenomatous polyposis. If you use it as a term of something that protrudes and has dysplasia, those progress quite frequently, particularly if they have intestinal or mixed gastric and intestinal differentiation. So if a patient has what most of us would call an intestinal type adenoma, their entire flat mucosa is also at risk. So it's worth asking the colleagues to go back and sample the flat mucosa.
Another question is, I know it was not touched upon in the talk because it was not relevant, but do you do MSI testing in gastric adenomas?
No. Unless
Ah.
there's a special request, like the patient's 25 years old.
Yeah.
But the yield is going to be low. Even in the colon, if a patient has Lynch syndrome and you test adenomas, only 50%, 50, half will show loss of the relevant protein, encoded by the mismatch repair genes. So the yield is much lower in the stomach.
Okay, one observation during the practice is, you mentioned the hypermucinous type of change. We see it in the conventional dysplasias as well. Is it, does it have any significance?
No, they might be a little more likely. So you're talking about the hypermucinous colitis associated dysplasia.
That
They
is
may
correct,
be
yeah.
more likely to progress, but absolutely you can see that as a component in very ordinary colitis associated dysplasia. In fact, the colleagues who coined that term now want to call it gastric type dysplasia. I think the main thing about that is just to recognize it. And I think in the past, many of us may have overlooked it. So I think that's the main thing about it is, hey guys, this is something to pay attention to. It's just as bad as any other dysplasia. Don't blow it off as nothing. And I know you have a good eye, so I'm sure you've been spotting it for a long time.
Thank you. Another question regarding the indefinite for gastric display, in the gastric biopsies, indefinite for dysplasia, where you mentioned the regenerative epithelial change, So we get regenerative gastropathy cases, and we sometimes struggle whether to alarm the clinician to get a repeat biopsy or not. How do you tackle that?
So I rely very heavily on.
Does my question make sense?
Yes. So I
Okay.
rely very heavily on the microscopic criteria to see that maintenance of cell-to-cell polarity with those 4 lines that I kept showing, and it works very, very well. Of course, our population may be lower risk. We, in the population here in Miami, we have about 13% Helicobacter. I'm going to guess yours is higher. When I worked in Baltimore,
Yeah.
there was only 6,
Yeah.
7% Helicobacter. If you have a higher fraction of Helicobacter, you may be wanting to suggest treat and repeat, particularly if the patient has Helicobacter. But most of them, in my opinion, are readily solved just by paying attention to that cell-to-cell polarity.
Okay. Well, Dr. Montgomery, this is all for you now. Thank you so much. Truly appreciate your time. Honestly, it was such a deja vu listening to you live, and it was very nice. And everybody, a lot of compliment from the audience. They enjoyed your talk, and they were very thankful as well. Hopefully, next time we will invite you to come in person and see the whatever city we will arrange the meeting, and so that you can see Pakistan as well. Thank you so much. Truly appreciate your time.
That sounds lovely. I want to hear what Dr. Clay has to say. His talk was really nice.
Albeit a little fast.
Okay.
It's hard to record a talk when you don't get audience feedback.
Okay, sir, how are you?
I'm doing great. Go ahead, hit me with them.
Okay. So since spindle and pleomorphic lipoma share the genetic RB gene loss with atypical spindle and pleomorphic lipomatous tumor, can we call it to be a spectrum of the same disease process?
It's a good question. I'm going to go with, at the moment, no. And so, although a lot of the atypical spindle cell pleomorphic lipomatous tumors look a lot like spindle cell lipoma or pleomorphic lipoma, there are some key differences. One, the location is pretty unusual. I mean, extremities are not typically where you see spindle cell lipomas. 2, the circumscription is not really the same. So there's a little bit of higher chance of recurrence. But also, that's an entire spectrum. Although most of them look sort of like spindle cell lipoma, they can look quite bad and quite different. I sort of would, I think, mentally wrap them into the RB1 family of things. You know, mammary type myofibroblastoma also looks very similar, has the same type of collagen, can have fat, but is definitely not the same distribution, not the same tumor type. And so I keep them in my head in the differential of each other just so I can remember them. But I don't put them into the same camp as of yet. And it's still early days with that entity, so it's hard to know. On paper, certainly they have a lot of overlap, and some of the photos have a lot of overlap, but there are definitely cases that do not adopt that that particular morphology.
Okay, thank you. Okay, next question is, are the CHIC, BCOR and EWSR rearranged sarcomas managed on the same lines clinically yet? Or are there specific therapies available for each of them?
Good question. So at the moment, most institutions are handling that on the fly. And so we know that B-core rearranged tumors tend to be less aggressive than Ewing and certainly less aggressive than CIC rearranged sarcomas. However, there really aren't targeted therapies for them yet. What we've adopted is sort of a situational case-by-case sort of approach. If a tumor is small, it's B-core, it's completely excised, margins are negative, they might not do adjuvant therapy. Whereas, CIC sarcomas are going to sort of be treated more aggressively, but with like the same therapies. And so it's very dependent upon location. You can sort of think of it analogous to like a chordoma. Like chordomas can be very easily resected and essentially benign, but you can have them in places where they kill everybody. And so I think a lot of it depends on where they are located, how early they're caught, the size they are, and how well the patients respond to therapy. But no targeted therapies as of yet, but you can sort of think of them as like risk groups if you put them all on the same spectrum.
Okay, next question. So we recently started doing NGS on solid tumors. How are you using it in clinical practice? Because for us it's for us it's challenging. A, it's very expensive. B, so we have to run it on the batches, so turnaround time is a bit tricky. So and C, clinicians, they do request it, but they don't know what to make it out of it,
Yeah.
kind of situation.
Yeah.
So
And so the good thing is I'm also a molecular pathologist. This is something that's sort of close to my wheelhouse. I think there are lots of different ways you can use NGS in solid tumor sarcoma, whatever it is, depending on your volume and your needs. And so people want it because it's, exciting, and most of these entities I'm talking about are defined by molecular alterations. I think number one would be like on the back end. Like maybe you can't get it done quickly and it happens eventually. Can it refine diagnosis? Because I think that's a big deal. 3 weeks out, if you can further define a diagnosis, that's very helpful and can definitely alter therapies. So I think that's one, just sort of like making sure you're not finding things that you didn't expect or catching, mistaken diagnoses with molecular alterations. I think that's one. Number two would be some clinical trials, certainly in the United States, require molecular alterations for enrollment. So that's one thing. But I think from like a global standpoint, we have all this data. What do we do with it? I think you can go real basic. I think one thing that people are finding is that just like the number of mutations a tumor has very much correlates to how aggressive that tumor is, right? So tumor mutational burden. Everybody wants that reported now in our cases. Now, again, it sort of puts you in risk camps. Maybe it doesn't change diagnosis, but when you get a Ewing sarcoma that just has a fusion, or you get a Ewing sarcoma that also has a p53 mutation and a whole bunch of other alterations, those tumors are going to be more aggressive. And so maybe you can bump them up on the treatment list. Maybe you can get them in early. Maybe you can be more aggressive with what you're going to do, just based on sort of how many mutations are sort of happening. One of the biggest limitations we find is like just sample quality. Like, can you even get data from a sample? I think to your point, I think the way to sort of tackle this stuff is to do the biggest panels you can and batch as many things as you can. Once you're doing enough cases, it's actually cheaper to just like look at everything and like pull the data out that you care about. That's what we're doing now. We've transitioned to essentially just running larger and larger. We've collapsed all of our panels into one, because you need one assay, you need one technologist that understands it, you have one informatic pipeline that sort of looks at the data, and it makes it a lot cheaper, but also makes it a lot easier, because then you can sort of subset out the data you really care about, and spend less time analyzing data and less time sort of fishing for things. But I think, does it save you from making a messed up diagnosis? Can you find sort of novel things? A lot of those aren't really useful. Like if you think it's a Ewing sarcoma and it happens to be CIC, they're probably gonna get the same therapy anyway. And so
Sure.
I think it's a super difficult question. I think the biggest impact for your patients would be major diagnostic swings.
Sure.
Do we have tons of mutations on boards that point toward maybe some sort of a syndrome or some sort of a more aggressive phenotype? And then, all the research things that sort of fall into the back end of that, which is also very helpful, especially with a place like what you're working with, where you have such a huge encatchment, and you get so many cases from so many diverse regions. Those data sets are very powerful to help characterize the disease in your population. I'll take good morphology and a great H&E over NGS any day, and I do both. I want the perfectly optimized fixation, and a great section I think is so much more important than in-depth molecular analysis. But I like to do both, but I think you know what I mean.
Yeah. Okay, that I think that's very relevant what you mentioned. Thank you so much. So that's all for now from us, and truly appreciate your time. Hopefully, I will see you in person someday.
Yeah, for sure.
Okay. Thank you. Take care. Have a
Have a good
good
one.
day. Okay. Bye. Bye, Dr. Montgomery.